food.
The basic problem we are discussing today, all over the world.
Abu, this is Dr. TSC from Chennai.
Hi, how are you?
And you become so popular along with the Vivek call in India. We will be seeing you more frequently in webinar than what we used to have the
Yeah, I agree with you. I agree with
Thank you.
TSC.
Very kind of you.
I wonder whether you people are living in India.
Well, it's an honor. I call India second home. I love India.
So you
Hi,
love
Vivek. Welcome.
Hi, hi Vivek. Hi everyone.
Hey, man, how you doing?
Hi, Vivek.
Congratulations! Congratulations on your new position. Or where are you now? Right now, are you still in northeast, or are you?
Yeah, still in the Northeast. I'm flying out today to meet my family in Ohio, and then I have to go via Mexico to Florida to get a work visa.
Interesting. Yeah, we've all been through those challenging routes with the immigration, but hopefully with the immigration stuff will open up a little bit. But congratulations, good luck to you in your new position.
Thank you so much. I'm excited to join Barham and work with you.
Yeah, I know.
Yeah, I could say now, hello partner, you know?
Yeah,
exactly.
I was going to say you'll be speaking to Barham even more often now. So
yes, we will.
Cheers to you guys.
Hi, Vivek.
Hi, good morning. Good evening.
Dr. Chandrasekhar from Chennai.
Hi, great to meet you. Thanks for the opportunity to be part of today.
All Abu's and your video on gastroplasty.
Yes, a little bit of fun.
Where are you going to join now?
I'm joining the Mayo group in Florida, in Jacksonville, Florida.
Okay. My son is doing advanced fellow in Mayo, Arizona.
Oh, fantastic! Fantastic. Good. We have
his
lots
name
of colleagues.
also Vivek.
Oh, really? Well, I hope people get confused, and maybe I can benefit from his greatness. You know.
He is Vivek Chandrasekhar, no?
The Viveks are going to take over now, right?
I think so. That's good.
Abu, my son did a systematic review with meta-analysis.
Very nice.
Like father, like son.
Hi, Mr. Jairaj, sir.
Hello, sir. Good evening, sir.
Right.
Hello, sir. Good evening, Dr. Ashish. Dr. Kaur, good evening. Good evening. Yeah, Jairaj. Yeah, hello. Dr. Anil Sahab, good evening.
Good evening, sir. How are you?
I'm good, sir. I've been
Nice
getting these messages from you. Yeah. Good evening.
Mr. Jairaj, we missed you for our...
Yes, sir. Last time, yeah. I joined actually at 8 o'clock. The webinar had started. And by the time I landed and then again opened, it was over. Yeah.
So Anil, do we know how many people have registered here yet? Or
maybe organizers may be able to tell us. I didn't inquire specifically.
Pranita?
Yeah. I'll just tell you in a while.
Yeah.
And the questions will come in the Q&A section or the chat section. Do we know? The audience questions.
I think it's preferable to
It'll come in the chat section, sir.
Okay.
I will post it to you. Yeah.
Okay.
Ms. Pranita, digital interview manager, she'll be posting it to the specific speakers also. Sir. The questions, she'll be going to the questions and she'll be posting it. Yeah.
Sounds good.
Vivek, you have a very nice backdrop. What is this backdrop?
You know, this is Rochester downtown, actually. So I'll get out of the way.
Oh, fantastic.
So, you know, Rochester is a mid-sized city. And whenever my friends from New York City, you know, we used to meet, now, like Baram said, back in the 19, they always used to make fun of me. Like, you're from the village and we're from the city. So I decided I'm going to go out and take
Mayo Clinic is in Rochester, no, sir?
I'm sorry?
Mayo Clinic is in Rochester, right?
No, yeah, that would be where Barham is. That's another story. We can talk about that another time.
That's even a smaller village. You won't get
Yeah,
that
that's
picture
a
yet.
smaller village. I have that conversation with Prasad all the time. He's a good friend of mine. And so anyway, so I said, let me post a picture that will end the controversy. So that's the best we can do, I guess, from this city, I guess. So.
Mr. Jairaj, if
Yes.
people have joined, how many have joined? Any idea? Then
Yeah,
we can start.
Yeah. So we
Pranita?
have about 163 people watching us live. We have 163 people
Are we
watching.
live already? Discussing.
Yeah, we are live now.
All right, that's good to know.
Should we start?
Yeah, we can start.
Okay. Yeah, good evening, everybody. And good morning to those who are joining from the western part of the world, especially Dr. Abu, Dr. Vivek Kaul and Dr. Vivek Kumbari. And I'm extremely thankful to all those who have joined on this very interesting session on endoscopic management of obesity. From Daily Liver Foundation, I welcome you all on our fourth session of a series of webinars on obesity. Today, we are going to focus on management of obesity, especially the endoscopic version of it. In fact, of all the aspects of the science, the yawning gap between the availability of the knowledge and failure to give results occurs in obesity. Even with ever expanding knowledge of energy homeostasis as well as the mechanisms of obesity, we still are not able to stop the unrestrainable epidemic of obesity far more than what we see in COVID era. COVID is going to go back soon, but obesity as a pandemic is going to persist. As per the WHO, 30 to 40% of the population in the world suffers from obesity, and it is going to increase by a whooping 30% over the next 2 decades, leading to all the social, political, economic, physical, psychological barriers. How to overcome these barriers? We have been trying to do a lot by studying the pathophysiology of the obesity, the role of diet and exercise, and all of us know that these have the limitation, and final answer is surgery. So today we are going to make an attempt to look at the endoscopic ways of controlling obesity, as most of us as gastroenterologists will prefer to avoid surgical option as the last option. So with that, may I request Dr. Ashish to please carry forward the proceedings.
Good evening, ladies and gentlemen. I bring you greetings from Sir Gangaram Hospital, and on behalf of the Delhi Liver Foundation, I welcome you to this webinar on obesity. But prior to the academic feast of the lectures and discussion on endoscopic treatment of obesity, the Delhi Liver Foundation would like to felicitate one of the greatest gastroenterologists in India. As you all know, from last 3 years, the Delhi Liver Foundation's in the memory of Dr. S.K. Sama has been recognizing and felicitating senior gastroenterologists who have made significant contributions in the GI and liver field in India and who have dedicated their life in improving the GI and liver health of Indians. Today, the gastroenterological expertise in India is one of the best and at par with the world. Be it any field of GI specialty like hepatology, luminal gastroenterology, pancreaticobiliary sciences, or the therapeutic endoscopy, Indian gastroenterologists have made remarkable contributions all over the world. They have produced path-breaking research and remarkable innovations in endoscopic techniques. Today, we would like to honor Professor D.K. Bhargav, who is one of the pioneers of gastroenterology and gastrointestinal endoscopy in India, for which the Medical Council of India had awarded him the B.C. Roy Award, the highest Indian award in the medical category. In addition, he is also the recipient of the civilian honor of Padma Shri. So now I would like to hand over the proceedings to Dr. Munish Sachdeva, who will first tell about Dr. S.K. Sama, why his contributions in gastroenterology, and Dr. Vikas Singla will read out the citations on Dr. D.K. Bhargav. So Dr. Munish.
Thank you, Dr. Ashish. I hope you can hear me, Dr. Ashish.
Yes, 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 we can hear you.
Can you hear me?
Yes, yes.
We can hear you.
Thank you, Dr. Ashish and Dr. Anil, for giving me the opportunity to introduce our president as well as our founder of ILGPS, Dr. S.K. Sama, who is always with us in promoting all those activities in academics, in clinical science, whatever way possible. He is always there to help us, and very unfortunate to lose her in year 2017. But as such, what I had interaction with Dr. Sama, he was such a nice gem person, not only as a person, as an academician, as a founder member, as a trust to hospital. He's always help us in pushing the department in giving some or new innovations in the field of gastroenterology. So I'll like to introduce the audience to Dr. S.K. Sama. Basically, Dr. S.K. Sama was a person who was born in 31st May at Firozpur. He did his schooling from Himachal Pradesh, and his medical education was basically MBBS from Medical College Amritsar and MD Medicine from All India Institute of Medical Sciences Delhi. And then he went for his fellowship from Boston to have a gastroenterology fellowship. He had a brilliant career. He started his career by joining the alma mater All India Institute of Medical Sciences, where he stayed for about 2 years. He joined there in 1974 as one of the professor of gastroenterology, and then he also promoted to GB Pant Hospital. In 1976, he joined Sir Gangaram Hospital as honorary physician of gastroenterology and served the hospital for 36 years, including as being as a chairman, as a trustee, and during his tenure, continuing his association with Sir Gangaram Hospital, he founded the multi-speciality hospital, which is known as Sama Hospital in 1982 in South Delhi. He was also a personal physician to President of India in 2001. At Sir Gangaram Hospital, he not only did ambitious work in gastroenterology, he also founded the gastroenterology department at Sir Gangaram Hospital. And as I said, he always tried to create every work in field of gastroenterology and hepatology to that extent that it was known as Center of Excellence. He held various posts at Sir Gangaram Hospital, including that of founder member of Board of Management and also a member of Board of Trust. He also chaired the Board of Management from 1995 to 2006. As a teacher, he was par excellence. He was an excellent teacher. As I said, I am his one of this student, and his devotion to academic remained with him till his last breath. He was really a role model for people like me and many other medical students and budding gastroenterologists. He was a pioneer of medical research on liver disease in India. He published approximately 51 impact articles in various national and international journals. His 1962 article reported as first attempt to describe the non-cirrhotic portal fibrosis. He also credited significant research in the field of hepatitis B, and he had always been inquisitive and had the zeal to learn latest technique in field of gastroenterology. His contribution to medical society as an Indian partner, he was former president and a life member of Indian Society of Gastroenterology, and he had organized 6 therapeutic endoscopic workshops. He was a life member of Indian Society of Study of Liver Disease, Indian Society of GI Endoscopy, American Gastroenterology Association, as well as Association of Physicians of India. He was also the president of New Delhi chapter of Indian Medical Association. He was board of advisor of American hospital management companies. As I said, he received a number of awards, but one of the few awards which really renowned him was the Government of India research on liver disease, including non-cirrhotic portal fibrosis and hepatitis B. He received the highest Indian medical honor, that is Dr. B.C. Rai Award in 2004, and he was also a recipient of several other awards like Punjab Ratan Award, DMA Ratan Award, Bharat Jyoti Award, Bhaskar Award, and so many of others, which I can't be narrating all this in very few slides. He had also delivered lectures as presidential oration, as Dr. B.L. Kapoor Memorial Oration, Dr. K.L. Wig Memorial Oration, and so many of others. And in the last, what I can conclude to me as well as to Gangaram Hospital, he was really a father of gastroenterology. He was really a teacher of the teacher, astute physician, able administrator, and the vision what he had for his hospital as a countryman to India. I can't express all those things on these few slides, but I really feel that these are my heartfelt contribute to my teacher, Dr. S.K. Sam. Thank you, Dr. Ashish. Dr. Ashish?
Yeah. Now I would like to invite Dr. Vikas Singla, who would read a citation about Dr. D.K. Bhargav. Dr. Vikas.
Yeah, good evening, everyone. I agree with Dr. Munish that Dr. Sama is like father of Indian gastroenterology. And there cannot be a better deserving candidate than Dr. D.K. Bhargava for the Dr. S.K. Sharma Oration Award. And Dr. D.K. Bhargava is a recipient of multiple awards and the honors. He has the 4th highest civilian award, Padma Shri, in 2008. He was awarded the highest medical award in India, B.C. Roy National Award in 1989. Then he received Amrut Modi Unicamp Prize for Gastroenterology for his work in field of abdominal tuberculosis and the adenomas of the GI tract. Yeah, good evening, sir. Yeah. And he is also recipient of Hari Om Ashram Award by the MCI for his research in the gastroenterology. He is also recipient of R.M. Kasliwas Prize for the best work in chronic disease in India. He was awarded the Osaka Award in 1992 by the Japanese Society of GI Endoscopy. He is also recipient of Park Davis Oration. He is also recipient of the Shirley Award by the ISG for the best paper during the plenary session. He is also recipient of Olympus Mitra Award by the ISG for his knowledge in the endoscopy. Dr. D.K. Bhargava obtained his MBBS and the MD degree from SMS Medical College, Jaipur. Then he moved to USA and he underwent his fellowship program at the prestigious Memorial Sloan Kettering at the New York. In 1977, he joined All India Institute of Medical Sciences and he became professor of gastroenterology at AIIMS, New Delhi. In 1982, he received PhD degree for his pioneer work in abdominal tuberculosis. Dr. D.K. Bhargava is an excellent endoscopist. He has many achievements to his name, and he is founder of many techniques in the field of endoscopy. At AIIMS during 1977 to 1981, he started the colonoscopy in India. Then he started the endoscopic sclerotherapy for the esophageal and the gastric varices during the active bleed. He also started the endoscopic injection therapy for the duodenal ulcer. He also started endoscopic extraction of the foreign bodies. We can see that all the procedure, nearly all the procedures has been started by Dr. D.K. Bhargava in India. And he also organized more than 25 seminars after 1978, which has been attended by nearly 250 faculty members every year. In these seminars, various diagnostic and therapeutic endoscopic procedures were demonstrated, and he has been a guest faculty performing the various endoscopic procedures at Bangkok and the prestigious Prince of Wales Hospital, Hong Kong. and he has been pioneer in starting the gastroenterology at various institutes. He started the gastroenterology at SGPGI Lucknow, and he was an advisor to the UP government. He also is a pioneer to start the gastro services at prestigious IGMS Patna, and he was an advisor to government of Bihar, and he has been a visiting professor to many prestigious universities, to name the few: at the Brown University, Rhode Island, Showa University, Japan, and the Memorial Sloan Kettering, New York. And he has been a guest faculty and delivered more than 300 lectures in various national and international conferences. And in the field of science, he has made an excellent contribution. He has a pioneer work in abdominal tuberculosis. Now we know that colonoscopy is a tool to diagnose colonic tuberculosis, and initial studies were published by Dr. D.K. Bhargava. He mentioned the colonoscopic findings or the ileocecal and the colonic tuberculosis. We all know that ADA in the ascites fluid is crucial for diagnosis of abdominal tuberculosis or the tubercular ascites. That concept was given by Dr. D.K. Bhargava, and he has a pioneer work in GI bleed. In the field of portal hypertension, he is the first to start the injection sclerotherapy for the active vessel bleed, and he has shown that in patient with the decompensated cirrhosis, injection therapy is as effective as surgery. And he has also shown that in patient with the poor hepatic function, sclerotherapy was better than the propranolol. And in a randomized trial, he has shown that polidocanol was better than alcohol and the sodium tetradecyl sulfate. And he has also shown that omeprazole is not effective against the post-EST or the post-EVL ulcer bleed. And he has also done pioneer work on EVL and has shown that EVL plus EST is better than the EVL alone without extra complication. Again, in the field of non-varicose bleed, he has a pioneer work. He is the first one to start injection therapy for the gastric and duodenal ulcer. And similarly, in the lower GI bleed, he started the colonoscopy and started various therapeutic interventions. And he also has a pioneer work in the colorectal adenomas. He has shown that colorectal adenomas are not uncommon in Indian population, and he is the first one to show that colonic polyps occur in Indian population also. He established the diagnostic criteria for the gallbladder cancer and the Budd-Chiari syndrome. He has many publications. He has more than 150 publications in various international and the national journals, and which has been cited widely in various national and international journals. And he has presented paper more than 70 national and international conferences. And he has delivered guest lectures across the world related to abdominal tuberculosis. And I think Dr. D.K. Bhargava is the founder of the Indian Endoscopy, and he truly deserves the award. Over to Dr. Ashish.
Thank you, Dr. Vikas, for reading the citation about Dr. D.K. Bhargav. Now I would request Dr. Anil Arora to invite Dr. D.K. Bhargav to say a few words about his journey in gastroenterology.
It is my proud privilege and duty to invite Professor D.K. Bhargav, who has been our teacher, mentor, and philosopher and a guide, to receive this award from us. Professor Bhargav, please. We would love to have some few words from you. Can you unmute yourself, sir? Dr. Bhargav, can you hear us?
Can you hear me?
Yeah. Yes.
Okay. Actually, I'm thankful to you and the other organizing members of the society, Liver Foundation Society. And I want to say a few words about how the gastroenterology evolved in India. Now, when I joined the AIMS in 1977, there were 4 stalwarts in the field of gastroenterology in India: B.N. Tandon in Delhi, Dr. Antia in Bombay, Dr. Madan Gopalan in Chennai, and Dr. S.K. Mehta at Chandigarh. All of them were very good clinicians and doing research work in their field. At that time, we have no imaging techniques like ultrasound and CT scan. Now, there were very few lacunae in the field of endoscopy at that time, and there were only 3 to 4 upper GI endoscopes in India, because I came to know from the Olympus distributor in India that how many endoscopes we have in India, and they told that we have 3, and that was seen in one in AIAMS, one in PGI Chandigarh, and one somewhere in Pune. So then we thought that my idea of coming India was to only develop this field, because this was non-existent at that time. So we purchased, as soon as I joined, then we purchased a colonoscope in the institute, because that was lacunae. And one must, I may say, that the first colonoscopy was started in in Jaipur, because I came to visit India during 1976. At that time, there was a conference on proctology, and the conference was held in Delhi and as well as Jaipur. So Jaipur asked me to bring a colonoscope for America, and so I brought one of the colonoscope from Memorial Hospital where I was working there, and they gave me one colonoscope that you can take to India. So I brought it, and first colonoscopy was done in Jaipur, where hundreds of students and teachers were there, and we demonstrated in a patient who had a lesion in the splenic flexure, which was detected as colon carcinoma, and he was going to be operated. And I did colonoscopy, and it was found that it was tubercular, so surgery was avoided. So that was, so first colonoscopic in India was conducted in Jaipur. Now, then we joined here in 1977. We purchased the colonoscope and started doing regularly. Now, for various colonic diseases, and that was helped because we started detecting newer diseases which were seems to be non-existence. For example, the first polypectomy was done in January 1978, and it was done in a person who was working in PTI. And so after removing his polyp from sigmoid colon, which was a large polyp, so he went to PTI and then says that the tumor was removed without surgery. And this was a throughout the India, it came in next day in the news media that this kind of surgery is being done without operating the patient. So subsequently, Dr. Antia called me from Mumbai that I have never seen a polyp in the colon in my whole lifetime. How can you see? Then I have to send him the histopathology slide that, sir, this is the adenoma which was detected. So then later on, we started found that more and more adenomas were coming, though they were not very common. But nowadays, what we see is that we often see the colonic adenomas. Then another field which was interested to me, because laparoscopy we started at AIMS, and Anil, as you know, that we were doing in a side room in the theater in the ward, AB2 ward, and we were doing laparoscopy because at that time we do not have the facility to do the see the lesions in the liver and peritoneum, because even ultrasound was not available, CT scans were not available. So we did laparoscopy and started doing biopsies from the liver lesions as well as from the peritoneum. And this was very useful procedure at that time. And then we detected how the gallbladder cancer can be diagnosed, how we can see the Butt-Chiari syndrome, etc. So then you know that all the endoscopic therapeutic procedures were started for varicose sclerotherapy, as well as for to take out the foreign bodies, and everything was done. And all these procedures were established between 1977 and 1981. And the first thesis I gave on colonoscopy with Dr. Vij, and he started doing colonoscopies with me at that time. So he was the first person to start colonoscopies with me. Then we started doing endoscopic workshop for every 6 months, and we were calling 10 to 12 persons because at that time we do not have the latest endoscopes which we are having. At that time we have only a attachment and one person was able to see. So we were just calling 10 to 12 persons and we conducted 28 seminars. And I was going from city to city to establish the endoscopic procedures and purchase of endoscopes in other cities also. Now, another interesting feature was that ERCPs were started first by simultaneously by Dr. Dilavari in Chandigarh and Dr. Krishna Rao in Chennai. And then later on, Dr. Rakesh Tandon at the AIMS started ERCPs also. So that was all these procedures. The ERCPs came little late by 81, 82, or 83. And that completed our armatorium. And with the help of endoscopic workshop, we were able to open several centers. And slowly, we had 1977, 3 or 4 endoscopes. And by 1984, 85, we have 5,000 endoscopes in India. So that was the revolution which occurred. Now, because of these procedures, we have published many papers, several papers on every field of endoscopy. Then subsequently, the DM candidates from AIMS as well as from PGI Chandigarh were able to start endoscopy centers wherever they go from Delhi. And some of them were in Delhi also. Now, this is the latest example is Dr. Reddy, Nageshwar Reddy in Hyderabad, because he superseded all our DM candidates, whether they were from Delhi or from Chandigarh, and up to the level that he could establish Asian Institute of Gastroenterology in Hyderabad. And I'm thankful to Dr. Reddy that he awarded twice to me in Hyderabad in various conferences the medals. So this is the height where one can reach in this field of gastroenterology in private sector. Now we can say another factor was that Dr. S.K. Sama, that Dr. S.K. Sama left AIMS in 1976. And after he left, then I joined the institute and occupied his room because he vacated his room on the 3rd floor. And then they allotted me that you can sit here. And then I came to know that the great Dr. Sama was sitting. And then I called him and we became friends at that time. Now, he was very interested to develop endoscopies in Gangaram Hospital after he joined there. And it was very good that we conducted a workshop in Gangaram Hospital for the first time, and I was being called as a chief guest. And at that time, Randir Sood already joined the Department of Gastroenterology at Gangaram Hospital. And subsequently, Dr. Anil Arora, who is the organizer, he also joined the field. And both of them, the Randir Sood and Anil Arora, started developing the gastroenterology at Gangaram Hospital. And we can see it is one of the finest departments in the field of gastroenterology in India. Now, I can say that several centers in our country are at par with developed countries because we are not lacking in any field. And in endoscopic techniques, now we are going to 3rd space endoscopy. And as I heard, Dr. Arora has more than 200 cases where he was able to do all types of 3rd space endoscopy. Now, another feather in our country was that now we have almost 80 to 100 centers giving DM degree and DNB training in our country. And we are producing large number of gastroenterologists. And so thus this is the evolution of gastroenterology, that from 1976-77 onwards, and now it is 2021, that we are able to achieve, and we are at par with any developed countries of the world. So I am again thankful to the organizer of Liver Foundation, Delhi, for honoring me today. And because of this is a virtual, so I have, you can see that I have put the medal myself. And thank you, Anil, very much. I am really proud of you that you are doing regularly the conferences and developing the Department of Gastroenterology. Thank you. Even my son, when my son Sandeep, when he came to know, then he says that Anil Arora is your best student, which I know. So again, thank you, Anil.
Thank you, Professor Bhargav. I think Dr. Vivek Kaul and Dr. Vivek Kumbhari will agree that nobody on the earth will give you a platform of base station in Nepal of Mount Everest, that is Dr. D.K. Bhargav, and the tip of the Mount Everest, Dr. Professor Nageshwar Reddy, in the same frame. Would you agree, Vivek?
I completely agree. I was going to felicitate and congratulate Dr. Bhargav for that excellent history and for receiving this great honor. Dr. Bhargav, as you know, Sandeep and I know each other very well. We spent a lot of time on the East Coast, and please convey my regards to him as well. But also that Dr. Sama, as I was growing up as a young child and young adult in Delhi, Sama was the name everybody knew, and very familiar with this institution in South Delhi, and a big loss to the society. Very great felicitation and very deeply personal for me for a variety of reasons. So thank you all I'm very honored to be here, Anil, and you're again doing a great job. Thank you.
Thank you. May I hand over the proceedings to Dr. T.S. Chandrasekhar for carrying out the scientific session.
Thank you. Thank you, Anil.
Thank you, sir. Thank you, sir.
And what a platform Anil has created. The best of people who are going to deliver on obesity, and what a great timing, relax and enjoy in the weekend. And who will have better than the panelists Anil Arora, Vivek Kumbhari, and Barham Abudai, and Nagi Reddy. You can't ask for anything more than this. I must congratulate Anil for this wonderful platform you have created. And without wasting much of time, I have my greetings to Vikas Singla and Munish, who nicely conduct the proceedings. And my co-moderator is Dr. Vivek Kaul is here. And the topic is a contemporary topic. And the speakers are wonderful. And we are going to have a change in the scenario now, since Vivek has to catch a flight. Is it right, Anil?
Yeah,
you want to
Vivek
talk first?
had requested, yeah.
You want to talk first? Or you are going to talk first? Anil?
Vivek wanted, he says that he's a flight. I'm ready. Vivek, what do you want, Vivek Kumbhar?
Physiology is very important, no? Just, Vivek, can you wait for 15 minutes?
I'm so sorry. I have a 10 o'clock flight.
Right. Okay,
then you can present yours.
And
yes.
I will request my co-moderator, Dr. Vivek Kaul, to introduce Dr. Vivek Kumbhari. He has to catch a flight, and he is going to talk. He will introduce the topic, and Dr. Vivek too. Okay? Go over to Vivek. Too many Viveks are there. Vivek
I know that they're going to take over the world now.
And my son also, Vivek.
Thanks, TS. Dr. Kumbhari, welcome to the series, and very excited to have you here. For the brief introduction, Vivek, came to the US from Australia. I think as an advanced fellow at Hopkins, if I'm not wrong, and very quickly, did great things there with the excellent team there, and has focused, of course, a therapeutic endoscopist, but focused his efforts in bariatric endoscopy, metabolic endoscopy. He's trained many fellows and faculty nationally, published a lot, and gained notoriety in this field. And most recently, as of I guess last week or two, we realized he's moving on and is going on as associate professor and director of advanced endoscopy at the Mayo Clinic in Jacksonville. And we wish him luck for that, and he's going to do great things. And Florida is increasingly becoming a medical hub in this country. The original medical hub was Boston, New York, Texas, and now it's Florida. So congratulations, Vivek, on that. And the topic that he's going to talk about today is a very interesting and very important topic, which is to say that our endoscopic sleeve gastroplasty and endoscopic restrictive therapies come of age, and are the results, outcomes, the impact similar to our surgical counterparts. So that's a very, very important topic, and Vivek is going to shed some great light on that. So welcome, Vivek, and thank you, and good luck, and safe travels.
Thank you, and good evening, everyone. It's a pleasure to be here. I'm sorry for the change in order. There's very limited flights now to anywhere in the country because of COVID, and so I apologize for being so restricted. I'm very proud to be part of this series. I've been watching the other series recorded that Dr. Harora had sent me, and I'm very excited about the future of joining Baham, and also Dr. Nagi Reddy at AIG, which is also a Mayo affiliate, for a very promising future for all of us. So this topic is very personal to me. My PhD thesis revolved around a similar theme, and I hope to intrigue you somewhat. Just some disclosures, I work for several companies in the endoscopy and bariatric endoscopy space. So to kick this off, I wanted to give some perspective as to where endoscopic bariatric therapies should sit ideally. And this is some very important data from the New England Journal of Medicine, a randomized control study by Phil Shower, which compared medical therapy to surgical sleeve gastrectomy to gastric bypass. And there's some observations that you can see here from this important data. So these were patients with BMI under 40. And so these are in the obese category, and certainly within the realm of what we hope to treat endoscopically. Now note first that surgery is superior to medical therapy. And then second, although there's a statistically significant difference, there's a very small difference in change in body mass index between the sleeve gastrectomy and the bypass, despite them being incredibly different procedures. I find it quite intriguing. The second thing I want you to notice is that even in the setting of a randomized control study, heavily funded, very close follow-up and surveillance of patients, patients in the surgical arm started to gain weight at 18 months. This is normal. And this is what happens even more so in the real world. So when we contextualize endoscopic therapies, one must also assume that somewhere between the 12 to 18-month mark, patients are going to start gaining weight. What's also fascinating about surgery is the dramatic improvement in glucose homeostasis. And so the graph on the bottom shows the change in BMI over time, and the graph on the top shows the change in glycated hemoglobin over time. What you can see here, the reduction in HbA1c is far more steep than the reduction in weight. So clearly there are weight-independent benefits of bariatric surgery here. And Baham wrote a nice letter in the New England Journal of Medicine recently, commenting on an article that was referencing this. What's also important when we think about endoscopic therapies, people often criticize it, saying, well, the total body weight loss is much less than surgery. It's insufficient. Losing 10 kilos doesn't make a difference. And I wanted to highlight this data from a meta-analysis, which I thought was interesting. Basically, if you lose 10% of your total body weight, so if you're 100 kilos and you drop 10 kilos, you lose 10% of your total body weight, you lose a 23% reduction in the toxic fat, the visceral adiposity, and a 52% reduction in hepatic lipid content. So that's significant, and that's clinically meaningful, and I think that is a worthy target for an endoscopic therapy. Not ideal, we can do better, but that is a place to start. So in brief, again, to contextualize what I'm going to talk about next, what are my goals for an EBT or endoscopic bariatric therapy? I think it needs to be appealing to patients and providers. We need patients interested, and we need endocrinologists, cardiologists, gastroenterologists to refer patients. If they don't like a procedure, it doesn't matter. It needs to be safe. That's the biggest concern for patients considering bariatric surgery, and it needs to be well tolerated. And we're going to hear more about balloons from the world expert Baham soon. But I think one of the bugbears of the balloons is some issues pertaining to tolerability. I think we need to get in there early, particularly in the Asian and Indian population. BMI 27 or above is a suitable target. As mentioned, I think a total body weight loss of 10% at 6 months or 12 months is important. I think because obesity is a recalcitrant, persistent condition, it should be a repeatable procedure, potentially reversible. In view of how effective bariatric surgery is, we don't want to do anything that will compromise future bariatric surgery. And importantly, I think the improvement in metabolic profile should be superior to what is experienced with weight loss alone. And this is my biggest criticism of the endoscopic space. Currently, I don't think we've demonstrated in depth that we are achieving a weight-independent benefits of our procedures. And lastly, and this may be somewhat controversial, but my vision is that somebody essentially walks into a shop, buys a pill, swallows it, and somehow they walk out without seeing physicians, etc. And this is happening in the US. I can tell you that there is a technology called Plenity or Gelesis 100. There's a pill you swallow and you drink with water. It's FDA approved. You actually buy it online. You log in, they do a 15-minute sort of nonsensical visit virtually, and you get it. You get a 3-month supply for $80. So, I think this is the future, direct to consumer, and this is what we've sort of seen more and more with the COVID pandemic. So endoscopic sleeve gastroplasty, and it's really a pleasure to talk about this in front of Baham. He published the first paper on this and worked on making this prime time, which I'm very happy to say it now is. So essentially, you take the stomach from a floppy, expandable bag to a stiff, compliant tube by placating the degraded curvature of a stomach in the body and somewhat in the fundus. And when you compare it to laparoscopic sleeve gastrectomy, arguably the gastric lumen is the same size at the end of the procedure, although you haven't resected the gastric tissue. And so this is what it looks like. I use the overstitch endoscopic suturing system. There's a single channel, double channel, a 2 non-absorbable suture. You take full thickness bites of the stomach. You start like surgery, 3 centimeters proximal to the pylorus and come up to the GE junction. And you see a lumen like this. This very much looks like a sleeve, almost watertight, stiff, thin, non-compliant tube. So, people often, particularly bariatric surgeons, talk about, why are you doing ESG? We tried laparoscopic gastric plication. There was initially some interest, but it never really worked. So I wanted to look into this further. The gastric plication story is very interesting. One, it's a very cheap procedure. Laparoscopic instruments are reusable. A suture costs almost nothing. And so you can do this procedure at very low cost. Now compare it to a surgical sleeve, which uses stapling guns and staplers. It's a much more expensive procedure, several $1,000s in the US at least, just for the equipment. And so, I wonder if industry was biased. The big companies, Ethicon, Medtronic, J&J, are actually, we're trying to crush the gastric plication as it may have even hurt their potential revenue. So there were multiple studies published comparing laparoscopic gastric plication to surgical sleeve gastrectomy. And just for those who aren't familiar, laparoscopic gastric plication is doing a very similar thing to ESG. You can push the degraded curvature of the stomach. You sort of dissect the omentum off the stomach, free the vessels and vasculature off the degraded curvature, push the stomach inside the lumen, and then you do full thickness sutures. Now, clearly the sutures are full thickness, they're done laparoscopically. So let me show you some data from systematic review and meta-analysis comparing laparoscopic sleeve gastrectomy and surgical sleeve. And as you can see here, there is no doubt at 6 months that the surgical sleeve gastrectomy group has superior weight loss. So I agree. However, to say that laparoscopic gastric plication doesn't work is simply not true. We see in this analysis that they still had a 39 to 71% excess weight loss. And at 12 months, there was still a 46 to 67% excess weight loss. So yes, I agree. Laparoscopic gastric plication is not as effective as surgical sleeve. However, it is still very effective. And so I think it is very suitable that we try and emulate a similar thing endoscopically. This is a systematic review and meta-analysis that Baham and I published, looking at ESG over time. Again, it's a review of retrospective data, and Baham has headed a multi-center randomized control study on ESG, which I think is critical. But you can see here that weight loss tends to start to plateau around the 6-month mark. And there is some sort of durability in weight loss efficacy out to 18 to 24 months at 17%. However, this is retrospective data and there are problems with data collection. The adverse event rate for ESG is low. Serious adverse event rates as low as 2%. As this disseminates widely over time, we'll see what happens. Again, this is a review of retrospective data where there could be a bias to not collecting data on serious adverse events or people not publishing if they have significant serious adverse events. But anyway, from what is in the literature, it's 2%. Now, what happens to the stomach over time? This is a question often asked. And I think when you do ESG, this is what you see. So this is 9 months post ESG, and I've got similar videos, 12 months and 2 years. You can see that the stomach is non-compliant, but the sutures have dehisced. You see here, the sutures have opened up. This is not unexpected. If you suture the skin, it's not going to stay there for 5 years. It'll slowly become superficial and fall off. The stomach is a very dynamic organ with acid secretion. It's very hostile. There's a lot of movement, tissue regeneration. Why should the suture stay exactly as you left it? However, look at the fibrosis in the gastric body. There's certain fibrosis here, and so I suture quite proximally, and this is all the way up in the fundus, as you can see here. So this thing doesn't open up and fall apart if you do it properly. And there is some people from Europe and South America who have raised concerns, and there may be some technique-related issues there. How does ESG compare to high-intensity diet and lifestyle therapy, HIDLT, which is frankly the gold standard? It is superior than high-intensity diet and lifestyle. 21% total body weight loss in our patients, this is case match data, towards 14% total body weight loss with high-intensity diet and lifestyle. 14% is very high, much higher than sort of normal studies. Now, importantly, how does ESG compare to the lap sleeve gastrectomy? Well, even at 6 months, there's a difference. So as early as 6 months, the laparoscopic sleeve has superior total body weight loss to the ESG. However, there was less reflux-related events with ESG, and if we have time, we can talk about that later. And as mentioned, the sort of level 1 evidence is coming through Baham and his collaborators. But what about combined approaches? We published this data comparing endoscopic sleeve gastroplasty to plus liraglutide to ESG alone. And this was a very simple, again, case match study of patients who were offered liraglutide at 5 months after their ESG. And you can see here, if you take time 0 as 5 months after the procedure, you can see that the ESG plus liraglutide group had superior total body weight loss than the ESG alone. So if we're looking to try and emulate some of the hormonal benefits of bariatric surgery, maybe bringing in a GLP-1 agonist like liraglutide could be important to try and get to those better outcomes. Now, however, where do we need to go? And I always mention this. The light bulb was not invented by trying to improve the candle. Real progress involves rethinking how endoluminal therapies are performed rather than simply using new technology to replicate old processes. I think if we just take new plication equipment, clips, whatever it may be, to make the stomach small, we're missing out on a real opportunity to do better. We need to think differently. So my ultimate goals for an endoscopic bariatric therapy is that it should have efficacy similar to bariatric surgery. It should be safer than bariatric surgery, and it should be more cost effective. And I believe if we direct our energies towards these in the right manner, then we'll get there. If you think about the different players with regards to weight loss, you have the patient. The patient wants an outpatient procedure, an incisionless procedure, something that's well tolerated and a single intervention. The providers, us, gastroenterologists, want a technically simple procedure that's performed under conscious sedation, is safe and effective. And the insurance companies or the governments, they want a cost-effective procedure and something that has long-term improvement in metabolic outcomes. And so I wanted to raise this very interesting study. And I think that the study sort of missed an opportunity here. And I wrote an editorial attesting to why. But endoscopic sleeve gastroplasty versus laparoscopic sleeve gastrectomy versus laparoscopic gastric plication, what are the outcomes at 2 years? And so the image on the top left is a normal stomach without a procedure. The top right is an ESG. Bottom left is a surgical sleeve. And bottom right is a lap gastric plication. And one could argue that at least at the end of the procedure, the stomachs look similar in size, apart from the normal on the top left. And you can see here from data from the outcomes analysis, there were a different N in each group. This is not matched data, but you can see here that the procedure time, even in the surgery groups, was under 1 hour. So this idea that surgery takes forever may not be that true. The length of stay was longer in the surgical group than gastric plication, but in fairness, there are some centers in the US with selected populations that actually do a surgical sleeve gastrectomy as an outpatient procedure. Let's keep that in mind. So even some surgeries being done in outpatient. And yes, the adverse events are much higher with surgery than ESG. But this to me is the most interesting thing I hope to show you today. So ESGs on the bottom, gastric plications in orange and LSGs in green. At 6 months, there is a substantial difference in total body weight loss between surgery and ESG. And that difference is maintained at 2 years. Now, if the initial problem or criticism of ESG was that the stomach expanded over time, and that was the reason why it was not as effective as surgery, then what one would expect to see is very similar weight loss at 6 months, and then a change over time with surgery continuing to perform better and ESG plateauing or doing worse. But that's not what we're seeing here. From the outset, there is a difference in terms of efficacy between ESG and surgery, and it has more to do than change in size of the stomach. And so, similar to the title of this talk, I wrote this editorial based around this data. And you know, I think comparative studies, ESG and surgery, are good because they allow us to have data-driven conversations with patients. They help us guide a personalized approach. And if you have a patient with severe metabolic disease, you know, insulin-dependent diabetes, then you know, surgery really is the optimal treatment strategy if they're open to it. But I think more so, comparative studies are hypothesis generating. There are other studies that reveal that surgical sleeve or LSG induces a more favorable metabolic profile than ESG or gastric plication. In this study, you know, again, one must ask, lap gastric plication was superior to ESG. And so why is that? Well, what are the differences? There may be several, but gastric plication involves dissection of the greater curve from the omentum, and it interferes with the stomach's neurovascular supply. The stomach has to be mobilized before suturing. We don't have to do that with ESG. And maybe this mobilization causes some changes in gastric hormones and gastric motility. So what are thoughts about the future? Well, this is some images from a colleague in Australia, Adrian Satarera, where he combines ESG with argon plasma coagulation to induce scarring and to maintain the stomach being more tubular, to have a more appearance of the surgical sleeve. And you know, this is select images, of course, but it looks pretty good. You know, we published a similar case I did as part of a live endoscopy meeting in Brazil, and you can see here at 6 months, far more tubular, robust stomach with the combination. So maybe that's something to think about. And you know, this I find fascinating. Some might think it's out of this world, but this is I think a brilliant endoscopist, Bin Ronglu from China, who is a very out-of-the-box thinker, you know, like Tony Kalu and Nagi Reddy are. And what he did basically is EMR the stomach of a human patient, just EMR the stomach to cause scarring. As you can see here, the images on the top are at time 0, date of the procedure. On the bottom are at 1 month. You can see tissue regeneration. And the images on top are at 3 months. You can see the stomach scarred. And the CT images show a non-compliant stiffening tube, not that much different from surgery. So interesting that this is what people are thinking about. And you know, so just to think about the future, where do we go from here? Let's think about the factors at play in addition to gastric volume reduction. You know, one, I think the surgery causes an accelerated nutrient flow, an accelerated gastric emptying. Also, certainly in the case of gastric bypass, but even in sleeve gastrectomy, there's loss of nutrient exposure to the stomach as well as small bowel. There's alterations in the microbiome and there's alterations in bile acid metabolism. So I think there's lots of opportunity here. And in view of time, I won't sort of bore you with data, but you know, I've been working on a technology looking at ablating the gastric mucosa to try and achieve similar outcomes to the surgical sleeve gastrectomy. And we've shown this in rats, where we did algoplasma coagulation in rats. And we show, yes, there's tissue regeneration over an 8-week period. But when you do immunofluorescence for ghrelin, the XA-like cells, although you see tissue regeneration, the number of hormonal secreting cells is less. You know, the amount of peritoneal or retroperitoneal fat is less in the APC group. Visceral body weight is very similar between the surgery and the ablation group. So we thought we'd try to translate this toward the clinical realm, and we're currently piloting a clinical study doing this in patients. But we did this in pigs as well. We did a randomized study comparing APC of the stomach to sleeve gastrectomy to a sham group using a specially designed APC catheter, hybrid APC. You can see you can do wide field ablation of the stomach. It looks very aggressive in pigs, and we can see that at 4 weeks, there's actually no difference between the surgical sleeve and the GMD, which is gastric mucosal devitalization group. And when you look at the image on the bottom left, we did MRIs of these pigs. You can see actually there's no difference in visceral adiposity. Now, you know, admittedly, in growing pigs that are prepubertal, there's very little amental fat anyway. So, but the model's troubled, but I think it's interesting. We actually showed even that the GMD, so EGD with APC, actually improves blood pressure and reduces renin in a similar way to surgical sleeve. We've actually stained tissues for fat, and when you do fat staining with Nile red, there is also a reduction in the size of the fat droplet and the abundance of fat. So all very interesting. And we're actually working on a specially designed catheter to try and make this more efficient. But I thought I'd stop there and thank you very much. And I'm sorry to briefly step away, but I'll try and join the Q&A, and I'm very grateful for the opportunity.
Thanks, Vivek, for an excellent presentation. Covered it all. And again, safe travels, and hope you can join us back. I think the Q&A will be towards the end of this 4-talk session, right, Dr. Anil?
Vivek, he's leaving now. Want to have a couple of questions, if Anil doesn't mind.
That's true too. Yes. So
Yeah.
Anil, take a couple questions.
Because he's leaving the...
Yeah. Will he be joining, Vivek? Are you likely to join back?
I hope so. I hope so from the airport. I think I can.
Oh, that is fine. How long did it take you to reach the airport?
It should be 10 minutes.
Yeah.
Then it's okay. You can join us from the airport.
Yes.
And people in the airport also will be.
Right.
So sorry.
Okay. Right. Vivek, can I proceed with the next speaker? While
Please.
I'm going to invite Dr. Anil Arora, I just want to put it in record that I enjoyed the journey of gastroenterology or evolution of gastroenterology in India by Professor D.K. Bhargav. And we congratulate you on getting this prestigious Samavarison Award. Thank you very much, sir. And it's a great honor. Now I have a pleasant task to introduce my good friend, Dr. Anil Arora. Anil Arora is right now one of the leading gastroenterologists in the northern part of India. And he is the chief and director of liver gastroenterology and pancreatobiliary section in one of the leading hospitals known for gastroenterology, Sir Gangaram Hospital, New Delhi. What is most important, apart from his tremendous number of publications and energy to conduct his seminar and webinar, is quite hardworking, and he's got a great appetite to learn, update himself, and update others, arranging such a wonderful webinars. I think Anil Arora is known to most of the audience in this part of the country. So I welcome Dr. Anil Arora to start this a very important topic, pathophysiology of gut hormones in obesity. Over to Anil.
Thank you, Dr. Chandrasekhar. Can you see my slides?
Yeah, I see your slides.
Okay. The topic of my presentation is gut hormones in obesity, the very basic pathophysiology on which we base the underlying treatment by endoscopic measures. Obesity, all of us know, is defined as a BMI of more than 30 kg per meter square. It is a chronic progressive disease characterized by a number of associated medical conditions. But unfortunately, as I mentioned earlier in my introductory talk, that there is a yawning gap between our knowledge of the basis of mechanisms of pathogenesis of obesity, but very limited, very challenging and disappointing results when we talk of weight reduction. Obesity is a threat to mankind with availability of so much of the food and not much work to do. Let me quote this philosopher from France, Voltaire. Nothing would be more tiresome than eating and drinking if God had not made them a pleasure as well as a necessity. So eating is both a necessity as well as a pleasure. So where does it all lead to? Whenever you try to eat, there are two types of hunger stimuli. One of them is homeostatic hunger. That means every 12 hours, once you are fasting, your clock tells you that you are not eaten. You need to eat it both for calories as pleasure as well as pleasure. But then there is another component of eating which is called hedonic hunger, in which when you had just had a full meal, but still you are looking forward to have a sweet dish or a dessert, and this is called eating for pleasure. So there are two types of food which are going in. That homeostatic hunger, which is essential for maintaining your day-to-day life, and hedonic hunger, which tells you that you eat for the pleasure. In fact, hedonic hunger gets stimulated after getting positive signal from mesolimbic dopaminic pathways, and an increase in the dopamine signaling from nerve terminals originating in the ventral tegmental areas, VTA, onto the neurons in the nucleus accumbens is one of the reasons of defining it as a reward area. So whenever you eat a sweet dish or a dessert after a heavy meal, you are rewarded, you feel good about it. Maybe this is one of the area which needs to be tackled when you are trying to control the obesity. Let's see what happens in terms of energy homeostasis. So whenever your person is fat or obese or lean will depend on a balance between energy intake in the form of food and energy output in terms of your exercise and day-to-day activities. So feeding behavior will tell us how much you eat, and energy metabolism will tell us how much you're able to spend in terms of calories. All that happens in the brain in an area called brainstem, which gets input from the vagus nerves within the upper GI tract as well as the small intestine, and also the stimuli coming in from the leaky blood-brain barrier in terms of the levels of the hormones and the nutrients which are present in the blood. So all the stimulus ultimately land up in hypothalamus, which is subsequently processed by the frontal cortex, which is also then governed by the reward and the motivation pathway. Finally, a culmination of all these results in decision, which is in terms of either deciding whether you are hungry. If you are hungry, you will eat more and preserve energy, or you have enough of satiety when the signals travel down from the brain into the GI tract to tell you that you are having enough of satiety, stop eating and spend more energy. Where does the idea of these gut hormones came into being? Let me tell you about this mouse experiment, which was very well and very elegantly carried out. These are the basic mouse models in which if you give one normal mice enough of food at labium and ask him to eat as much as is possible, then nothing happens. But if you take out a specific gene and knock out that specific gene in this rat and ask this rat to have food ad libitum, so you have fat with equal amount of food as was given in a normal individual. This knocked out mice gene model makes the fat absolutely mice very fat and heavy. Now, if you same knocked out gene model is injected with the serum of the same mice, this mice does not gain weight. So this was an idea which came in for the first time, that there was something in the serum which determines your level of eating and behavior. So when you talk of short-term and long-term regulation of the appetite and hunger, there are two important issues. The short-term regulation depends upon what is happening in the GI tract. Is your stomach half or full? And what is the status of the nutrients and the sensing of the small intestine, which will ultimately determine. Long-term regulation of the appetite, hunger, and finally the body weight and obesity is dependent on two important hormones called leptin and insulin. So short-term is dependent on the GI tract, long-term is dependent on the leptin and insulin. Let me explain you how this happens. Let's say in a person who is having empty stomach, who is having a stomach which is not distended. The moment your stomach is not distended, you will have brain areas which I've already mentioned as hypothalamus, mesolimbic cortex, as well as the brain stem. So they decide whether you are hungry or you are having enough of food, that is a satiety state. Once the brain decides that you are hungry, it leads to production of a hormone called ghrelin. Now, once ghrelin is released in the empty stomach, it will go and stimulate the areas in the arcuate nucleus of the ventrolateral thalamus, which are stimulatory neurons. So these have neurons which are neuropeptide Y and agoutin G related peptide. So these neurons will stimulate the brain and lead to increased hunger and eating more. But once you are able to eat enough of the food, then the stomach gets distended. And once the stomach is distended, there is a lot of nutrient which will come up into the small intestine because the distension of the stomach can increase motility of the stomach. So a number of the hormones get released from the GI tract, and then they again enter the blood through the blood-brain barrier and now go and inhibit the inhibitory neurons. So once you stimulate the inhibitory neurons, that is area called POMC or POMC, propiomelanocortin area. So this is something which will suppress your appetite and will tell you now should have more expenditure of energy and stop eating. So this is what happens. So one way is that once you are distending the stomach because of the eating food versus once you have a stomach which is not full. So a meal increases gastric volume related mechanoreception, and this reception of the distension of the stomach increases the motility of the stomach. So more food moves down into the duodenum as well as into the small intestine. Whereas in the intermeal period, so this is meal 1, this is meal 2. In the intermediate period, you have low volume of the stomach, no distension of the stomach, and the food does not move down into the small bowel. What happens once you have the food moving down into the small intestine? This is all important because what Dr. Abu Dahi and Dr. Reddy are going to tell us as to what happens once you are having changes in the hormones. How can we handle these hormones? As you eat your food, there is distension of the stomach that leads to increased movement of the nutrients into the small bowel. As nutrients are getting absorbed and are being sensed in the small intestine, that leads to stimulation of the number of the hormones. Some of these hormones called cholecystokinin, GLP-1 and pancreatic polypeptide YY. These are the hormones which will decrease the gastric emptying. So that means they are giving you a sense of satiety. Whereas some part of the small intestine also inhibit ghrelin. Ghrelin is a hormone which increases your appetite, fills up the stomach, increases the gastric emptying. So as the food is traveling down the small intestine, this small intestine is not an inert organ. It's not a organ which is just producing areas and giving you the villous surface for absorption of the food. It is equally involved in release of the hormone, which will tell you whether the stomach should be distended or whether it should be emptied at a regular interval. So the sensing of the nutrients in the small bowel releases these hormones which will decrease the emptying of the stomach. So as the food is getting absorbed, something goes to the brain to tell you that enough is enough, you stop eating. What happens at the level of the brain is you have both inhibitory neurons and stimulatory neurons. So the ghrelin is the only hormone which will stimulate the centers in the brain to increase the appetite, where rest all the hormones which are known to us, PYY hormone, leptin and insulin, they will cause suppression of the appetite, thereby increasing the satiety. So the gut hormones have emerged as a key regulator for energy homeostasis and drivers for eating behavior. Dysregulated gut hormone section is implicated in the obesity and the compensatory biological response driving weight regain following energy restriction. So the major hormones major gut hormones which are known to us can be characterized as orexogenic or anorectic hormones. So the only hormone which is orexogenic, that means which increases the appetite, is called the hunger hormone or ghrelin. Rest all organ hormones, they tend to suppress the appetite and they stimulate the decrease in the intake of the food and increase in the expenditure of the energy. So the obesity occurs whenever there is an imbalance between the orexogenic hormone as well as the anorexogenic hormones. The more ghrelin is there, the more will be the increase in obesity. If you have less anorexogenic hormones like GLP-1, PYY, the more you are likely to have increasing obesity. So the ratio between orexogenic and anorexogenic hormone decides what you're going to have in terms of your weight. Where do these hormones get released from? Secretin and ghrelin typically is secreted from the fundus of the stomach by the PD-1 cells in the fundus of the stomach. K cells in the antrum of the stomach secrete a hormone called glucagon inhibitory peptide. You have a hormone called secretin, which is secreted by the G cells of the antrum. I cells in the proximal duodenum secrete this hormone called cholecystokinin. Then you have very important L cells, which are present both in the distal ileum as well as in the cecum, which secrete this so-called incretin, which I'll be explaining to you what this means. These are the anorexic hormones, which will decrease your appetite for eating. And it's very important to understand where are these located, because as Dr. Abu Dahai as well as Professor Reddy are going to tell us how to tackle these enterically, we should know what is the location of these enzymes. Ghrelin is located primarily in the stomach, and its level typically dips down as you go down the intestines. There is no ghrelin beyond, say, proximal duodenum. If you look at the cholecystokinin, it's primarily released in the proximal gut, and the levels go down into the distal gut. GLP-1, that is glucagon-like peptide 1, is primarily released maximally in the distal ileum, but the more concentration is seen in the proximal ascending colon or the cecum. Whereas PYY, just like GLP, is present more in the distal ileum and the proximal cecum. Let me tell you two important hormones which are important for us to know. Ghrelin is the only orexogenic hormone. It was discovered after the ghrelin receptor called growth hormone secretagogue type 1A receptor, which was discovered in 1999. The hormone name is based on its role as a growth hormone releasing peptide. The reason it is called ghrelin is because whenever you are hungry, your stomach starts growling. Grrr, grrr. That Proto-Indian European root called ghrelin was described for it to mean it that this is a ghrelin or growling like sound which it produces. It is a peptide hormone secreted by the P and D1 cells primarily located in the fundus of the stomach. So this will be important for any endoscopic therapist who is going to tackle obesity. What do we do to this area of the fundus of the stomach, which produces the maximum concentration of this hormone called ghrelin? As I said, ghrelin is the only orexogenic hormone which has pleiotropic sites of action. Its levels drop shortly after meal and increases before a meal and during fasting stage. In fact, if you do gastric bypass and try to constrict or resect the part of the stomach, there is a consistent decrease in the total level of the ghrelin. Second important hormone which I want to mention is something called incretin. Incretin are the two important hormones which are going to be the future of diabetic therapy and the obesity therapy in terms of its medical interventions. What incretin means is that whenever you have food which goes into the intestine, you have a high rise in the insulin. Now this insulin can rise because of the glucose going into the circulation and stimulating the pancreas to produce insulin. But the level of insulin which is produced by the incoming glucose is far more than would happen with oral glucose. This is called incretin effect. That means there is something in the hormones which, in addition to rise in the blood glucose, tend to increase in the stimulate the beta cells of the pancreas to produce insulin. So this is an incretin effect. That means other than increasing the blood glucose, these hormones directly go and stimulate the beta cells of the pancreas to produce insulin. So these are called incretins. Now this is the basic difference between the oral and intravenous glucose in a normal person. This is called normal incretin effect. But look at what happens in diabetics. In diabetics, the difference between the insulin level before and after meal is quite attenuated. So the concept that the oral nutrient glucose administration promotes a much greater degree of insulin secretion than given by isoglycemic infusion, that tells us and justifies the role of gut-derived factors, that is the hormones like GLP-1, in glucose independent stimulation of the insulin secretion from the beta cells of the pancreas. So the two hormones which are called incretins are GIP-1, that is gastric inhibitory polypeptide 1, and GLP-1. It has been shown that GIP-1 does not have much role in obesity, and we always talk of GLP-1, which stimulates insulin secretion and inhibits glucagon secretion. It improves beta cell function and mass, inhibits gastric emptying, reduces food intake, and lowers body weight in patients with diabetes and non-diabetic individuals. So it is doing everything to suppress the appetite, improve the insulin level, and increase the glucose utilization in the body. And hence, it has a lot of therapeutic effects. All of you are very well known about these facts, that you have GLP-1 analogs, including exenatide, liraglutide, which Dr. Vivek talked about, and other DDP4 inhibitors, which will increase the level of GLP-1, which will have its pleiotropic effects. To summarize, in summary, GLP-1 receptor antagonists and DDP4 inhibitors, they improve glycemia without intrinsic hypoglycemic risk. And these are the potent drugs for decreasing obesity and controlling the weight in patients with obesity and diabetes mellitus. What is the relation? What is the proof that what we are talking can be seen in clinical scenario? In fact, it has been very well been shown that individuals with obesity have blunted ghrelin reduction post-meal. As I have already shown you, in a normal person, once you eat your food, ghrelin level is likely to fall down. But look at this gentleman who is obese. There is no postprandial fall in the ghrelin. So that means there is something wrong with ghrelin, fails to decrease after the meal. In addition, in patients who are obese, there is a reduction in the baseline and meal stimulated levels of the anorectic peptide like PYY, GLP-1, etc. So look at this graph. In a normal person, as you eat, there is more and more PYY, pancreatic YY, that is anorexic hormones which will go into the blood compared to a person who is obese. So both PYY as well as the GLP-1 level, they fail to rise in patients who are obese. So there is a good scientific basis of trying to do something to the ghrelin and the anorexic hormone GLP-1 in patients who are diabetic. In fact, there is an excellent study published in New England Journal of Medicine of only 50 individuals who were having a BMI of more than 40. So what they did was they gave them a very low energy diet for a period of 10 weeks, and then these patients were subsequently followed up for next 62 weeks. They clearly showed that once you start giving very low fat diet, your total ghrelin level comes down and then gradually it goes up. At the same time, with passage of time, all anorexic hormones, they tend to decrease with passage of the time. That means once you stop having very low fat diet, your ghrelin level is going up. That means you are again likely to become fat, and your anorexic hormones, they will come down with passage of time. Thereby meaning that any lifestyle intervention is not likely to have any beneficial advantage over a long period of time. What about bariatric surgery? All of us know, as Dr. Vivek has very clearly shown, that bariatric surgery is currently the most effective treatment for people with severe obesity, leading to marked persistent weight reduction as well as changes in the metabolic parameters. It has been shown that there is an increase in the anorexic hormones, that is PYY and GLP, after bariatric surgery, and there is a reduction of the orexogenic hormone called ghrelin. Why does it occur? Let me tell you what bariatric surgery is. So this is the intact GI tract, and this is what happens in patients who undergo bariatric surgery. In this patient, what we do is that you cut the stomach at this level, and after a distance of about 50 centimeters from the DJ, you chop off the small intestine. The limb of this is the alimentary limb. This is anastomosed to the ruminant part of the stomach, and the remaining part of the so-called biliopancreatic limb is attached to the rest of the small intestine at 150 centimeters from the DJ. So what this results is in Roux-en-Y gastric bypass, the stomach is divided into a small upper pouch with a volume of about 25 ml as an isolated gastric remnant is created. The small intestine is subsequently divided, and this so-called alimentary limb is attached to the common channel at 150 centimeters from the site of anastomosis. So as a result, the ingested food enters the small gastric pouch and empties directly into the jejunum. The gastric remnant, isolated 50 centimeter, is connected to the jejunum 150 centimeter distal to the gastroenterostomy. What does this all lead into? Let's see, does it lead to weight loss? The volume of the stomach is greatly reduced to a small pouch, that is 15% of the total volume. Small stomach makes the patient full faster, and it generates the sense of the satiety earlier, and hence greatly reduces the food intake. This may be the basis of what Dr. Abu is going to talk about in terms of utility of the balloon. Secondly, the first part of the intestine, duodenum, is bypassed, and that amount of the nutrient absorbed is greatly reduced. This is something which is so relevant, and I'm sure Dr. Reddy will find it useful when you try to bypass the duodenum by the procedure which is going to show. So how does bariatric surgery affect the gut hormones upregulation in satiety? In a lean individual, you have normal level of satiety hormones. Whenever a person is obese, the level of satiety hormone is less because of the metabolic disturbances. Once you produce a bypass, because you are bringing the food directly in contact with the areas of the distal small bowel and the proximal colon, which secrete satiety hormones like GLP-1 and PYY, you are grossly increasing the amount and number of the satiety hormones. So with increased food transit, alteration in the bile acids, increased availability of GLP-1, PYY, as well as alteration in the microbiota in patients with bariatric surgery, there is a persistence of the weight loss. And this translates into decrease in the expression of the only orexogenic hormone called ghrelin. And there is a hyperplasia and increased expression of the L cells. L cells I have shown you in the distal ileum and colon. These are the enterochromaffin cells which produce the anti-orexogenic hormone like GLP-1, and there is a because of the bypass, you have expression of the altered short chain fatty acids after ruined by gastric bypass. More propionate is released that leads to increased production of the anti-orexogenic hormone GLP. So what this bariatric surgery is resulting is in a persistent weight loss. And there is also data to show that there are two hypotheses why there is a persistent weight loss after long surgery. The first is a concept called hindgut hypothesis, which suggests as soon as the nutrients reach the ileum, bypassing most of the jejunum, so there is increased exposure to the L cells, and their density and their density concentration amount which produces GLP increases drastically. Secondly, as you are trying to bypass the gut, that is duodenum, you are trying to prevent the secretion of so many other anti-cretin properties which can be bypassed by simply not stimulating the duodenum. So this will be very relevant when Dr. Reddy talks to us about bypassing the duodenum. So in the end, what happens in patients who undergo Roux-en-Y gastric bypasses? You have higher level of the anti-orexogenic hormone, that is GLP-1 and PYY, and there is a reduction in patient in the hormones which are related in terms of orexogenicity like ghrelin. So can we harness this our knowledge of gut hormones for treating obesity? In fact, there is already a concept of use of liraglutide. In fact, Dr. Vivek Kumbhari only today showed us that a combination of ESG and liraglutide gives you better results than ESG alone. Long-acting GLP work are coming into being, which can be given even as infrequently as once in a month. And there is a concept of new oral GLP analogs which are going to come into the market soon. There is a concept of trying to inhibit ghrelin acyltransferase that has been this is a concept called GOAT concept in rodents, in which if you try to suppress the activity of the ghrelin, you are more likely to have more of anorexia and decreased food intake. And there is also a concept that in patients with Prader-Willi syndrome, if you give antagonist of the ghrelin or desacylated ghrelin, which is inactive moiety, you are more likely to have persistent anorexia. So in future, ladies and gentlemen, we are going to have a combination of anti-orexogenic hormone like GIP, glucagon, PYY. This is called triagonism, coupled with the main hormone, which not only improves the glucose homeostasis, but also decreases the appetite, decreases the gastric emptying, and stimulates the brain to cause satiety. So a combination of anti-obesity, anti-diabetic medication is going to be the future of therapy. And these are the various studies which are in different phases of development, and hopefully we'll see the future of this therapy. To sum up, ladies and gentlemen, obesity and its associated diseases represent a major threat to the global health. Excess weight gain is associated with all the metabolic complications which are so well known to us. Obesity is a chronic condition that requires treatment, but most of the time it is fallible treatment without persistently good results. Energy homeostasis have identified gut hormones as the key regulators of the body weight, acting upon homeostatic and hedonic brain circuits to modify eating behavior. Changes in the circulating gut hormones are implicated in contributing to the development of obesity, as has been shown by their reversal after bariatric surgery. With that, I'll stop sharing the slides and hand it over back to Dr. Chandrasekhar.
Thank you, Dr. Anil, for a wonderful illustration of what is happening in the gut hormones. As you are aware that the gut hormones we have studied in physiology, how it can be exploited in the management of obesity, that is going to be the future. I think you'll have a lot of questions in the question and answer session. Now I have a pleasant task to introduce the other speaker, who is well known, and Dr. Bahram Abudai. He is a professor of medicine and director of advanced endoscopy, director of metabolic and bariatric endoscopy, Mayo Clinic, Rochester, Minnesota. And Abu had visited so many times, has been visiting also. And I always think that he lives in India. And he's a kind of fantastic research he has been doing, and is a role model to many youngsters to take up this area of research. And he has a multiple patents, apart from having multiple patients also. And he has over 200 research publications and more than 2,800 citations also. And he's the recipient of the Star of Science Award given by His Majesty King Abdullah II. And there's a long list of awards and so more to tell you about his biodata. But what I seen him is, above all, is a great human being. This I liked it very much. And over to Dr. Bahram, Professor Bahram Abudai.
Thank you, Dr. Chandrasekhar and colleagues. It's an honor. It's very humbling, and I'm not sure I deserve all these accolades, but I'll take them. Thank you. And without further ado, it's a distinct pleasure to be with colleagues from India. I keep saying this, but India is my second home. I love India. I love the culture. I love the people. I love the colleagues. So thank you for the kind invitation. Do you see the slides okay?
Yeah, fantastic. Perfect.
Excellent. So we're going to be talking today about space occupying of the stomach in obesity. Does that make sense? And where are we heading with this technology? These are my disclosure. I do work with many companies developing therapeutics in this space, and I hope to provide an objective and bias-free evaluation of these technologies. So before we go into the details, it's very important to discuss what's the unmet need, because that's the crux of everything we're talking about today. And if we look at a chronic disease like obesity and plot it against body mass index, we could see that the burden of obesity lies on continuum, and the inflection point of that burden starts at a body mass index of 28. That body mass index is actually lower in Asian population. However, that's the curve for a Western population. Then if you impose on that burden of disease graph the obesity distribution, you could see that the majority of patients with obesity have mild to moderate obesity, not severe obesity. Therefore, if you intersect the burden of disease over obesity distribution, you could see that the number of individuals with mild to moderate forms of the disease contribute 90+% of its burden as far as mortality, morbidity, and impact on health care utilization. So The more important part of this is that this cohort currently has no effective intervention to treat its disease. Yes, bariatric surgery is good. Bariatric surgery is reserved to severe obesity. We cannot apply it to 50% of the world population because the risks will be prohibitive and the cost as well. Therefore, we need a strategy to target those with mild to moderate obesity because they contribute more to the burden of disease than those with severe obesity. So with that view, again, these numbers have been quoted multiple times, but we're reaching about a third of the world population being afflicted by the disease of obesity. And we do need a spectrum of care that include lifestyle, medication, endoscopic bariatric and metabolic therapies, and surgical intervention in order to start addressing the significant burden of such disease. So let's talk about gastric devices, where we are, what's the patient population, what's the premise for use, and then I will share with you some of my future perspective on this field. We have multiple gastric devices to treat obesity and metabolic disease. People are familiar with intragastric balloon, but that's not the only space-occupying devices that we have. In figure B, we have a device approved by the FDA after a large multi-center randomized controlled trial in the US. It's called the transpyloric shuttle, where in a fasting state, the device is seated in the stomach. In a postprandial state, the device translocates to occlude the pylorus, delaying gastric emptying and resulting in significant weight loss at 1 year after implantation. And then in C diagram, we have the full sense device, which we've been investigating with our colleagues from AIG, which is a device that exerts pressure on the cardia of the stomach, where there's mechanical receptors. And these receptors convey the message to the brainstem, as Dr. Anil just described, in order to say that the stomach is full without having nutrients in it, hence the name full sense device. And we're going to talk about the implication of such technology very soon. So if we look at the intragastric balloon, over the years, there has been multiple designs. There's fluid-filled balloons, there's gas-filled balloon, there's adjustable balloons, and there's swallowable balloons. And all these that I'm showing here either have achieved FDA approval after large multi-center randomized trial or in the process of getting the FDA approval after completion of a randomized control trial in the United States. And we have multiple. We have the Orbera, which is a single fluid-filled intragastric balloon. This is the #1 balloon as far as volume in the world. We have the Reshape, which is a dual balloon system that this is no longer being marketed as Apollo, the company of Orbera, obtained this technology and decided not to market it further. There's the Obolon, which is gas-filled balloon that is swallowed as 3-balloon system, and then it's removed endoscopically. And then there's the SPATS-3 balloon, which is an adjustable balloon system, which allow you to start with a small volume to have the patient tolerate the balloon better. And then as the weight loss plateaus at about 8 months, you could increase the volume in order to increase the efficacy of this technology. And then there's the Ellipse balloon, which is a completely endoscopy-free balloon. You swallow the balloon, and after a 4-month period, the balloon self-excrete with feces. Again, all these have clear randomized trials. And if we plot these level 1 evidence, these are large, multi-center, sham-controlled or open-label controlled trial, you could see as a group that the weight loss achieved by these technologies is at least double, in some instances quadruple the effect that you see with moderate intensity lifestyle intervention. So their efficacy has been proven, as you could see, and the weight loss in general, if you take as a mean of all these technology, the average person will reach this critical threshold of 10% total body weight loss. And remember that number, because that number is going to be critical in how we evaluate these technologies, this 10% total body weight loss. So there's been a lot of talk about tolerance of balloons and some adverse events. The FDA issued a report of deaths related to the balloon, and it's very important to clarify this concept. Now, any technology has its risks, and balloon, if used indiscriminately in programs with no follow-ups, they could have population, they could have some adverse events. But in general, if you look at the randomized trial with high number of patients, you look at post-FDA approval studies, you look at meta-analysis with thousands of patients, and you look at consensus with 40,000 patients, you could see that the risk of mortality in the trials is 0. The risk of severe adverse events like perforation or bleeding is exceedingly low, which is lower than a standard colonoscopy. There is a small mortality associated with balloon that when you look at the meta-analysis, and it's at 0.03%, which is a similar mortality as you could see with almost any intervention that we do endoscopically. So yes, there's risks associated with balloon, but these risks are very low in the setting of a programmatic follow-up of the patient and high quality programs. Now, why do we use a temporary device, and what's the logic of using these technology? The logic is, as I told you, the vast majority of patients with mild to moderate obesity, which is inflected with metabolic disease, have no viable options at this point. And even those with severe obesity that do qualify for bariatric surgery, less than 1% of them, less than 1%, opt to get a bariatric surgery option, because we know there is no cure for obesity. And we know now the most common rate of incline of any bariatric intervention as far as surgery is revision surgery, because we know that everything without appropriate follow-up will likely fail with time, and we need to manage obesity as a model of chronic disease where we start with a weight, with an intensive weight loss phase to put comorbidity in remission. Then it's going to follow for a lifelong weight maintenance strategy, as highlighted by the AGA position statement that I will share with you. So that's a big reason why balloons or space-occupying devices could fit very nicely in getting the patient engaged, put obesity-related comorbidity in remission, and then couple them with other adjunct therapeutics like lifestyle modification, pharmacotherapies, additional endoscopic devices over time to manage disease as a chronic disease and keep it in remission for health benefit. Now, medications do have advantages. In large, the vast majority of available agents do not produce 10% or more total body weight loss, and there is cost efficacy issues. This is a cost-effective analysis we conducted with the Harvard group that shows that out of all the agents approved on the market, only Qsymia reached this cost efficacy threshold as seen by these graphs. And again, this is from the New England Journal of Medicine. If you look at responders rate, and the critical number here is 10%, because this 10% total body weight loss is associated with remission or resolution of the vast majority of obesity-related comorbidities. You could see that high-intensity lifestyle programs and pharmacotherapies do not reach this 10% total body weight loss. Now, there's newer agents that might reach this. They're still not available, and we look forward for pharmacotherapy to be an important adjunct therapeutics to these endoscopic interventions. So the critical point here that we're going to spend some time is how do they work and what's the impact on comorbidities, which is the critical concept here. And how we work, we spend a lot of time trying to understand these technologies. And this is the cultivation of this work. This is as part of the randomized trial. We did a sub-study that looked at the impact of balloon on gastric emptying. And you could see the story is clear. The graph is in blue is the intragastric balloon. The graph in red is the lifestyle control. And what we're plotting is percent gastric retention at 2 hours after an ingested meal. You could see at baseline, gastric emptying is the same between both groups. At 8 weeks and 16 weeks, there's significant delay in gastric emptying compared to the control group with the intragastric balloon. And after you remove the balloon, the gastric emptying returned to normal. So the major and predominant mechanism of action of fluid-filled intragastric balloon is a delay in gastric emptying, and that could have a significant impact on satiety and satiation for weight loss, but also have a significant impact in postprandial hyperglycemia, which is going to be a key determinant of the metabolic benefit that you could see beyond the weight loss that comes with these devices. And I will illustrate this concept shortly. So again, you could use this, this phenomena that, that intragastric balloon work on delaying gastric emptying to start selecting patient at baseline. That means patient at baseline who have delayed gastric emptying, they are not appropriate candidate for intragastric balloon, and you could go and offer them a different intervention in order to enhance tolerance and efficacy. And those with normal or rapid gastric emptying at baseline, if you give them intragastric balloon, they will be high responders without too much symptoms. So it illustrates the importance of understanding the physiology to better select the patient and enhance the safety and efficacy of the intervention. And again, that also has implication of efficacy of the technology. Gas-filled balloon is not as effective as fluid-filled balloon. They're better tolerated, but they're not as effective. And you could see we've shown this in a meta-analysis that the impact of gas-filled balloon is on gastric emptying is minimal compared to fluid-filled intragastric balloon. Now, we also proven this concept as part of the adjustable balloon randomized trial. You could see that starting with a smaller volume have enhanced the tolerance of this balloon, and adjusting the volume after the plateau of weight loss at 8 months resulted in 5% extra total body weight loss, illustrating the importance of this delayed gastric emptying, both on its effect of the balloon and on the metabolic benefit. And that's where I would like you to concentrate with me. If you look at what determines metabolic control or overall glycemic control, you could tease it down to fasting glucose or postprandial glucose. Postprandial glucose is the more important part of the equation. And again, here, if you look at procedures that delay gastric emptying, they tend to decrease postprandial hyperglycemia and the associated important metabolic benefit that comes with that. And if here you look at the figure with the plotted T50 and with the slower gastric emptying versus the area under the curve for glucose control, you could see that a delay in gastric emptying results in lower postprandial hyperglycemia and the metabolic benefit that comes with that, even independent of weight loss. And this is illustrated here. If we look at a disease that inflicts many, which is the lipotoxicity that comes with non-alcoholic fatty liver disease, the free fatty acid come from two ways: either free fatty acid from adipose tissue, and again, these are the weight independent effects of the balloon. If you lose 10% total body weight loss, the visceral adipose tissue will be significantly decreased, and that's one mechanism. But the second mechanism is this de novo fatty acid synthesis that comes from postprandial hyperglycemia. After we eat a meal, some of this glucose will make it to the liver. This will make de novo fatty acids. So again, the balloon seems to work on both weight dependent and independent mechanism of action, and it's related to its delay in gastric emptying as far as fatty liver disease. And we've shown this actually in an FDA study that might end up in changing the way that we look at patients with fatty liver disease. And we took 21 patients under a prospective FDA approved protocol, and we selected those with non-alcoholic steatohepatitis based on MRE and liver biopsies. We gave them the intragastric balloon, and we did another liver biopsies at 6 months. So it was a very intense, very expensive study to do, but we've done it. And what we've shown that with a single fluid-filled intragastric balloon on histological endpoint, you have 90% improvement in NASH activity score, 80% improved by more than 2 points, which is the FDA endpoint for any intervention for NASH, 50% improved MRE detected fibrosis by 1.5 stage, and 50% had resolution of NASH and regression of fibrosis. Again, illustrating the impact of this on comorbid disease like fatty liver disease. Now, talking a second unique mechanism of action, the hype is on intermittent fasting and all the metabolic benefit that comes with intermittent fasting on all the comorbidities that comes with obesity. And again, I would like to illustrate here, going back to the full sense device. This is a device that you place in the stomach. It activates the mechanical receptors at the cardia, communicate the signal to the brainstem and the hypothalamus that these receptors are activated. That means the stomach is in a full state. So without food, the patient have the sense of satiety. So this is a perfect device to allow patients to realize the benefit of intermittent fasting. And I think the next level of research here is introducing this device with an 18-hour fast per day to introduce the metabolic benefit that comes with this technology. And again, this is one of the patients that we've done with our colleagues at AIG that looks at this device. You can see this is the device. This is the GE junction. The GE junction is functional and there is no increased risk of reflux because the device does not bridge the GE junction. But you could see here in a retroflex view that the device is sitting in the cardia of the stomach, exerting pressure to activate the metabolic or to activate the mechanical receptors and indicate satiety to the central nervous system. So what's the future? The future is definitely a combination approach and pharmacotherapy. And again, there is the data for space occupying devices is mature. That made it to the to AGA position statement. And this is the one that is going to be published in 2021, which is an official AGA technical review and a position statement recommending the consideration of intragastric balloon for management of obesity and metabolic disease as a part of a comprehensive lifestyle intervention with the adjunct benefit of pharmacotherapies. So where are we going to go with this? Again, the key number here is 10% total body weight loss as an initial weight loss phase to put comorbidities in remission. But where we need to be in the future is we need to be in the gap where and we maintain it. And again, if you look at all obesity-related comorbidities, polycystic ovarian syndrome, diabetes, you could see that 10% weight loss could result in significant improvement or remission of these comorbidities. And here, so you plot all interventions that we have, medical, surgical, or endoscopic, and look at the responders rate of reaching 10% total body weight loss, you could see that the balloon outperformed all these drugs. ESG is better, and there's obviously the best is bariatric surgery, but you could see the spectrum of how we could start applying these technologies in this field. Now, going back to where these technologies fit, and this is the AGA position statement on how to manage obesity, and this is critical because this is futuristic in how we do this. Every patient needs lifelong treatment for a chronic disease. There is no fix for obesity. I'm sorry, it's not bariatric surgery. I'm sorry, it's not endoscopy. I'm sorry, it's not medication. It's a chronic management of a chronic disease, and it's management, not cure. Therefore, they recommend that we start with an intense weight loss intervention phase. Let's get the patient engaged. They see significant weight loss. They're more motivated to comply with lifestyle intervention. Obesity-related comorbidities go in remission. Then after so the intragastric balloons and space-occupying devices and endoscopic therapies have a key component of this initial weight loss intervention phase. Then you go into weight loss maintenance intervention, which here could include intensified lifestyle intervention, pharmacotherapy, Then it goes into weight regain prevention and re-intensification of effort, where you could apply this technology again and repeat the cycle. So there's no obese patient that should not be in one of these 4 quadrants at all times. That means you always have to be actively managing the patient and applying these technologies, whether medications, endoscopy, or surgery, to manage this disease. So again, the future is repeatable procedures. That mean balloon after balloon, or a balloon with an endobarrier, or an ESG with mucosal resurfacing. Combinable, we know there's a gastric pathway, as Dr. Anil showed us, and small intestinal pathways. So combining these interventions together makes a lot of sense. Sequential, so do endoscopic bariatric intervention, have the patient lose a significant weight, get them engaged, then add the medication. And now semaglutide is coming with significant benefit as far as weight loss and metabolic improvement. And then enhanced and personalized choices is going to be definitely the future of our field. And that's been the base of a new technology that we're developing with collaborator here, where we capitalize on advances in interventional therapeutic endoscopy, and also in the mechanism of action of how the stomach and small intestines both contribute in order to develop an anatomy preserving effective intervention that capitalizes on both pathways. And this is the single anastomosis endoscopic gastrointestinal bypass system. Now we could readily do an EUS guided gastrojejunostomy. We developed the technology to block the pyloric channel to delay gastric emptying. So you activate the gastric pathways, and also to bypass the duodenum. So now you could have, in one simple intervention, replication of the physiology of bariatric surgery, capitalizing on both gastric and small intestinal applications. So in conclusion, the GI tract is front and central in weight and metabolic regulation. Endoscopic bariatric metabolic therapy of all kinds will play a major role in the management of obesity and metabolic complications. The need is huge, and more intervention is needed, and personalizing the choice based on the preference and the physiology of patient is going to be key. So everything is fair game in this field. The future is bright in this field, and I would encourage more of the fellows to be considering lifelong careers with focus on the research and innovation in this space, because we're just starting with this field. And thank you for your kind attention.
Thank you, Professor Baran, for a nice exposition of what balloons can do in obesity. The last slide is the great slide. If somebody develops that, how you can do the GJ at the same time you can block the pylorus. So you will have the combination of both. And good luck to you for your patent to become successful. We will have a lot of questions at the end of the session. Now over to Dr. Vivek.
Hi, thanks, Dr. T.S. Baram, excellent talk as usual. And, with this difficult year we've had, it's good to see at least one slide that says the future is bright, right? So I think you're on the mark with that. The next speaker needs virtually no introduction, so my role could be very brief. It's my great honor and privilege to introduce Dr. Nagi Reddy, fondly known as Nagi. Welcome, Nagi, and thanks for joining and spending your Saturday evening with us. Dr. Reddy is going to speak about the enteric control of obesity and the role of small bowel interventions. I remember many years ago, I think it was at the Congress we had in Hyderabad, that I think we had a live demonstration of DMR, as it was very novel. And I think that was, they had a long-standing interest in that resurfacing technology, but others have emerged. And we look forward to your lecture on this. And congratulations, Dr. Nagi Reddy is chairman at the AIG Institute and well-renowned in this field and recipient of many, many national and international awards. So a great honor to have you speak here today, sir. Thank you.
Thank you. Thank you, Vivek. I'd like to start by thanking Anil for this opportunity to share this with both the privilege and honor of sharing with world leaders in this field, Vivek and, of course, Marham, whom we have been working with for a very long time. I've been asked to talk on enteric control of obesity and the role of duodenum and small bowel. And we just heard how both the stomach and the hormonal effects are there, which can actually determine your metabolic profile. Now, if you look at how the duodenum or the small bowel actually controls obesity, there are several ways. Of course, hormones. I think Anil has given a nice talk on the hormonal control. Most of the anorectic hormones actually are coming from the small intestine. This is one aspect. There's a neural control, and again we know that both through local hormonal and through a long neural routes going up to the hypothalamic, there can be controls from the small intestine, and this is again the ileal brake phenomena that has been shown very clearly. There's increasing interest in recent years, and now bile acid composition and bile acid mixing with the food can actually result in what happens in terms of I think. Your obesity and so on. And finally, there's some very, very interesting data on microbiome in the small bowel actually regulating your body weight and so on. But what I'm going to do, I'm not going to talk on all of this because this is a very large topic, and my interest, and of course the interest of the audience, would be another phenomena on the metabolic control of how the duodenum predominantly controls the metabolic process, and the so-called metabolic syndrome, where obesity is one component, with diabetes and probably non-alcoholic fatty liver disease, dyslipidemia, is all under the control of duodenum. And what as endoscopists we can do to change this. And I think Barham has already given a brief review of how blocking the pylorus and seeing that food doesn't enter can make a difference. So let me concentrate on that. Let me start first by this slide showing that all our thinking, all our knowledge for several years has been that the pancreas, along with its control on glucose metabolism, is the central player in controlling the metabolic pathways. I think this is now we realize this is wrong because nature had other methods. Nature actually has put the whole metabolic control in the duodenum, second, third, and fourth part of the duodenum. And this is obvious because whenever food enters, it has to first get in contact, at least the products of the food, with the small intestine, the duodenum. And this is definitely going to play the key role how metabolism is controlled. And we now realize that the pancreas, the insulin, the beta cells, and all these are actually secondary phenomena which depend upon the signals they get from the duodenum to actually control the whole metabolic situation in the body. Now, let me again show this to you graphically. It's a simplified way of what happens. When food passes through stomach, passes through the duodenum, it actually, you can see this as it goes through, it stimulates certain neuroendocrine cells, the so-called enteroendocrine cells in the duodenum. And this stimulation of neuroendocrine cells were originally labeled as incretins and anti-incretins. And again, Anil has touched on some of this. So these anti-incretins and anti-incretins either increase the insulin sensitivity or increase insulin resistance. So this is the concept that came. Now, the anti-incretins have now been replaced by the term insulin resistance factor or the diabetic intestinal peptide, because there's now some evidence that there's a peptide which is secreted from the small intestine, which actually could be the insulin resistance factor, and excess of this peptide could actually result in type 2 diabetes. So what stimulation of this incretins and IRF does is that it produces an euglycemia. And this euglycemia, of course, is the basis for a balance between insulin sensitivity and resistance and the whole metabolic phenomena. But what has happened over several years, millions of years, is that our diet has changed. We now have more refined diet, and these refined diets cause not only to stimulate incretins in the small bowel, but also more of anti-incretins. Now, the reason why this is important, this has an evolutionary mechanism, is that if you have a very high refined diet, you stimulate insulin very strongly, the insulin levels goes up, and then you have dramatic hypoglycemia. To prevent that, the body compensates by increasing the anti-incretins, or so-called insulin resistance factor. And because of this increased insulin resistance factor, there is an increased blood sugar, increased triglycerides, NASH. So the basic phenomena of control of the metabolic process in the duodenum is this secretion and counter secretion of insulin resistance factor and incretins. And as this regulation of this occurs, more of insulin resistance factor would result in, of course, the so-called metabolic syndrome, the basis of which is insulin resistance. Of course, obesity is one component of this, but other metabolic areas are also very important. We now know that the duodenum is the center of the metabolic activity. In fact, there is a huge amount of evidence, most of it being published in basic science journals like Science and Nature. So I don't want to go into details of this, but I think there is enough evidence to suggest that the enteroendocrine cells in the duodenum are responsible for a variety of things, including how glucose is metabolized by the liver and controlled by the liver, and how skeletal muscles utilize glucose, and more importantly, how it is processed in the hypothalamus in the brain, as Anil was telling us earlier. So all this, the central mechanism seems to be duodenum, and I think there's going to be much more exciting work coming out of this. And the most important work that seems to have come out was this duodenal intestinal peptide or insulin resistance factor, which has to now be identified. And I think this becomes very important. What is the evidence for this? There is a lot of evidence in the animal model, but even in humans, if we actually look at biopsies taken from the duodenal mucosa, you'll see that in type 2 diabetes, there are increased amount of cells which actually enteroendocrine cells compared to euglycemic individuals. And of course, in rats, this has been demonstrated by histoimmunochemistry. And this is a study where westernized diet was fed to rats to induce insulin resistance. And you can see how there's been marked increase in the chromogranin levels, indicating an increased enteroendocrine cells. So I think this is very obvious now. Some very interesting experiments came from work with this GK rats, which are spontaneously diabetic. And this is a work from Rubino's group, and I'll just show you this work to follow what happened. What they did was they took these rats which are spontaneously diabetic and then put these tubes across the small intestine, that is across the duodenum and part of the jejunum, to see what happens if food is bypassed. And you can see they had two types of tubes, one tube which was solid, the other tube which had fenestrations in it, so that most of the nutrients would pass through, but some of them would still pass through these fenestrations and act on the duodenal mucosa. Now look at the experiments. When they actually looked at these rats, those rats who had the solid tube, so no nutrient was exposed to the duodenal mucosa, had a normalization of their OGTT, the oral glucose tolerance test. But those rats who had no tube or even just fenestrated tube showed an abnormal OGTT, which is normal in these rats. So this indicates that even small amount of nutrient which was actually touching the duodenal mucosa was resulting in an abnormal response to glucose that is increasing the insulin resistance factor. So this was a very elegant animal study, and this has been further confirmed in the group, which showed that this is the concept that Barham has already told you about, that if you actually have rats exclude the pylorus and do a GJ, the diabetes improves, obesity comes down. But if you have rats in whom there is GJ, but the pylorus is still open, there is no effect at all. And that's the reason why when we had patients who had gastrojejunostomy done earlier, there's absolutely no effect on diabetes and obesity because pylorus was still open and this metabolic effect was not there. So basically, we now have evidence that the incretins and so-called anti-incretins in the duodenal mucosa, partly the upper part of the jejunum, actually control the metabolic process in the body. And again, some of the more convincing data has come from what happens in patients who undergo surgery, those who undergo Roux-en-Y gastric bypass. You see the weight loss occurs very late, but even by 4th day, they become hypoglycemic. In fact, the need for insulin and goes up. And I think why this happens, again, some very elegant experiment from Cumming and his colleagues, which has been published in the surgical journals, where they clearly showed the role of duodenum in the whole metabolic process. They took patients who were severely obese with type 2 diabetes, who were not on diabetic medicines, and these patients underwent surgery. And what they did was, these patients, when they underwent a Roux-en-Y gastric bypass, the hyperglycemic state, even after normal oral feeding, became normoglycemic. That is, the food was bypassing the duodenum, going directly from the stomach into the jejunum, and they were normoglycemic. And then what they did, which was of course the permission with the ethical committee, was to introduce gastrostomy tubes in the stomach in these patients, and then in addition feed them through the gastrostomy. And when they fed them through the gastrostomy, of course, the food was going, part of it was going into the stomach also. And then these people again became hyperglycemic. So just introducing food into the duodenum made them hyperglycemic. And when they removed it and again continued further, they reverted back to normoglycemic. This is, I think, a very elegant experiment which showed very clearly that the metabolic control was in the duodenum, and one could induce hyperglycemia just by nutrient passage through this duodenum. So I think this is a very important experiment that came. So how can one apply this into clinical practice? And of course, we know the concept of endobarrier. Endobarrier came very long back. Usually it started very early in South America, where the concept was just like Roux-en-Y bypass. We can put endobarrier to bypass the food into the from the small intestine into the jejunum. Maybe we can achieve the same result. So when endobarrier was used, clearly bypassing this, what was found was that weight loss was there, but very mild, not very significant, indicating that duodenum or the upper part of the jejunum had some role, but it was not a very strong role in terms of regulating body weight. But the more dramatic effect was seen in the metabolic issues like diabetes, and many of these patients, diabetic control became easy. So this concept was very good, but unfortunately, because these tubes had to be fixed in the duodenum, there was also some of these patients developed hepatic abscesses, and of course FDA banned this from further use. So we actually modified this, and this is still ongoing, putting in these tubes using with the Metamorphics, a company which of course Barham also has worked with, where we started using a special type of stent to put in these tubes now instead of the barbs. And as long as these tubes were there, there will be fairly dramatic effect in terms of reducing not only the diabetes, but insulin resistance. But unfortunately, migration is still there with these tubes. There are some modifications that are being brought in to see if you can avoid this migration. But whatever tubes you use to bypass the duodenum, the problem is it's transient. And this was again shown by this Dutch study, which showed that if we remove these endobarriers, once you explant them, again the body weight increases, A1C increases. So it's a transient phenomena, and the duodenal mucosa again comes back to what its original shape was, and patients start putting on weight, the glucose control goes off. So can something more permanently be done? And this was the basis for the work which has been done by a cooperative study from several units, both in Europe and US, where duodenal mucosal resurfacing concept came in. And the initial study in the same GK rats showed that using this special type of brush, they could brush off the duodenal mucosa. And once this is done, rats who had a duodenal abrasion with this mucosa showed much, much better in glucose control than compared with those who didn't have this. So this was the basis. Subsequently, that you can see this very clearly in these OGTT studies between these two types of rats. In the larger animal, again, this group went in further, and they did the swine studies where injecting saline under the mucosa, in the submucosa. They could lift up the submucosa, destroy this submucosa, destroy the mucosa without complications, and then the new regenerated duodenal mucosa did not contain the same enteroendocrine cells and therefore behaved separately. So does this translate into better control of metabolism and obesity? So this is of course the DMR procedure, which is well known now. It's pretty old actually, nearing 10 years now, where you can put in a guide wire on which you put a balloon with hot water. So this is a hydrothermal injury that produced to the mucosa after lifting up the submucosa, and progressively burn the duodenal mucosa from second part to the fourth part of the duodenum, resulting in injury. And therefore, the new mucosa which comes in actually doesn't contain the same enteroendocrine cells. And these are pictures to show you the pre-procedure duodenum. And after 3 months, you can see almost normal duodenal mucosa. A fairly safe procedure, very few complications reported with this. And now we have the newer type of balloons which are much easier to use, where you can combine the injection submucosally and the hydrothermal injury can be done with the same balloon. So it's fairly quick procedure that can be done, fairly standardized, and of course produces significant, at least 70% of the mucosa can then be ablated with this, and the resultant new mucosa, of course, has a different behavior. So this is the basis of this, and this several studies which have been done on this. The initial study, proof of concept study, was the Revita 1. Then came the randomized study, Revita 2. The INSPIRE study, which actually looked at insulin requirement in these patients, and Jack Davies unit in Brussels actually looked at what happens to NASH patients, and there's some interesting data from that. And of course, the Domaine study for polycystic ovaries in London. So many studies, and they all uniformly showed that after the procedure, lasting for up to a year, and now we have 2 years data, that A1C changes persist. There's significant drop of more than 1.5%, which I think is very significant when you compare to what happens with drugs. And also there's the famous gut study from the same group, again showing that there's not only drop in the A1C, but also there's insulin resistance comes down, the liver enzymes, and of course also AST and LT showed significant decrease. This was a study in Netherlands which actually looked at whether this therapy could decrease the insulin need, and you can see that in 50% of the patients there was significant decrease in insulin need, and these patients were off insulin. They were the patients who actually were needing insulin at fairly high doses, but once this was done, they could be switched off insulin. And again, further reports where the whole metabolic process has been studied. In addition to a decrease in weight, better control of diabetes, this insulin sensitization resulted in marked improvement in their lipids, in anti-inflammatory and antioxidant capacity, and more important, hepatic indices, including there's a decrease or reversal of fibrosis in these patients. I think very exciting data suggesting that all this metabolic control can be done with acting on the duodenum. But let me just divert a little here and come to two important slides that not only the metabolic control with DMR, but there are other studies in the small bowel which have shown control of obesity. And one of this is a study with Thompson's group in Boston have popularized. This is a magnetic anastomosis between the jejunum and ileum, or between the duodenum and the jejunum, which actually bypasses the food from the jejunum and can result in significant decrease in weight. And a human study has also been done to show that using two scopes, we can use this realigning magnets, put them together and produce an anastomosis in the small bowel. And bypassing the small bowel can result in decrease in weight. But this decrease in weight may not be just hormonal. There may be other factors like change in microbiome and so on. Very, very early data. And similarly, this very interesting microbiome study, animal study, but again, some clinical data to suggest that if you actually can transplant distal gut microbiota from obese to germ-free mice, they become lean, and lean mice become lean when distal microbiota are given. So you can actually change your metabolic profile, especially obesity, based upon this gut microbiota transplantation. So this is again some data, clinical data, which has come following, I think, FMTs that has been done in patients with IBD. We have evidence that if you do it from an obese donor, the patient also can become obese. Again, I just wanted to divert from the whole metabolic process to say that the control of obesity from the small bowel is a very complex phenomena, which includes hormones, microbiome, maybe bile acids, a variety of phenomena. We still haven't understood it completely, but we have now a capacity to manipulate this. Manipulate because we know that the duodenum has a metabolic role in causing insulin resistance. And this is, I think, a physiological role which came from evolution. Hyperplasia of the duodenal mucosa can result in abnormal enteroendocrine population, resulting in, of course, all the insulin resistance that we see. And as endoscopists, we can manipulate this area very easily. I think as endoscopists, we have an answer for the metabolic syndrome, and the answer seems to be similar, simple endoscope. And as again, Barham showed you some very exciting devices that are coming in, which can actually manipulate the entry of the food into the duodenum, bypass of the food to the duodenum, and so on. And I think ultimately we have an answer as endoscopists to many of this. This is ongoing, I think very exciting. We are in the threshold of witnessing some very dynamic changes in this new area. Thank you very much.
Thanks, Nagi. That was excellent review, and also some new insights into understanding how difficult this is. It's not, especially in the small bowel. Once you cross the pylorus, things get more complex, and this has been also part of the reason that it's been an Achilles heel in obesity management, metabolic endoscopy over the years. This is not new approaches or new ideas in the sense. But we've been trying for a long time, and you have highlighted some of the reasons why it's been difficult to make progress in that particular section of the foregut. Thanks again to all the speakers. I think at this time we should open up the Q&A section, and hopefully we have some audiences. Dr. TSC, do you have any questions that came through
And
the audience here?
thank you, Anil, for the opportunity. 4 brilliant lectures from the very eminent speakers. I have a lot of questions have been already here in the chat box. And the first question is, Anil, you said very difficult to control hedonic hunger. And you said gut hormones can be manipulated towards the obesity management. We are talking about obesity management with the endoscope and laparoscope and surgery. What is a person's status of a gut hormone, long-acting gut hormone can be tried? And what are the studies underway? What do you look at the future of that?
Yeah. You see, the complexity of understanding the basis of obesity lies at multiple levels. As I said, there are 2 types of hunger which are initiated in a human being. One is a homeostatic. That means if you are having low glucose in the blood, if your blood levels of the leptin and insulin are low, as is expected with hypoglycemia, obviously the ghrelin will go up and you will feel like eating. But this all is occurring at the level of hypothalamus, which is then super governed by a place called mesolimbic cortex, which releases hedonic or so-called reward phenomena, in which just for the pleasure of it, I remember I quoted that French philosopher's quote that eating is both a pleasure as well as necessity. All of us know it is a necessity, but somewhere if we can skip over that pleasure by looking at these complex neuronal interactions between mesolimbic cortex as well as the hypothalamus, we may be able to do something. But so far as now is concerned, as Professor Abu Dahai said, if we are able to engage the patient in terms of relevance of obesity and its ongoing metabolic complication, I think you can get over hedonic component of the hunger over and above the need for gut hormones. If they understand that you continuing eating for the heck of pleasure is going to put you down the drain, certainly that will be help. Understanding these neuronal circuits in the brain is hell of a job. I don't think we're going to see the light at the end of the tunnel soon.
Thank you, Anil. A question to Dr. Abu is, who is a subset of obesity people would be benefited by balloon, so that we do not want to try everyone? And is there any mechanism where you can fix the balloon with the fundus of the stomach, where all the things are getting, like ghrelin and other things are there? And if you fix the balloon in the fundus, will it work? There are 2 questions in this. Which balloon and who is the preferred one? You have to unmute Professor Abu.
So the first one, thank you for that question. This is a complex question, but first part of it is easy. Yeah, it's easy to answer because we already have the data. So yes, we could select a group of patients who we could maximize the tolerance and the efficacy of the balloon if we utilize gastric emptying. So what we do is we do gastric breath test emptying at baseline. Those in the quartile, the slowest quartile, we suggest alternative therapies, because we do not want to take somebody who starts with a slow gastric emptying and give them even further slowing of the gastric emptying. And those with normal or rapid gastric emptying, we select with the balloon. So doing this simple intervention could significantly improve tolerance and efficacy of that intervention. So that's easy. The second part is, could you fix balloon in the fundus? And that's where it is a misnomer. Fundus regulate appetite and satiety in normal physiology. Expansion of the body on fundus is what's triggered the brain to stop eating, and then emptying of the fundus also has a critical role. So this concept of eliminating the fundus has not panned out in this. And actually now we want to increase the interaction between food and the fundus, because most of these ghrelin suppressing signals is the food chemically interacting with the fundus, not eliminating the fundus. So taking concept from bariatric surgery does not apply to bariatric endoscopy, because with surgery, what do? You dissect the stomach, you denervate it, so connection with the brainstem are no longer there. So really the role of ghrelin in surgery is trivial at best, and there is not a single study that showed that changes in ghrelin, GLP-1 or PYY have any impact on hard endpoint, whether metabolic or weight. So taking surgery as a model is a flawed for the field that we're doing, because we need to understand normal human physiology, not an abnormal artificial system. So I do not advocate for balloons in the fundus. Actually, the balloons need to sit distally in order to delay gastric emptying and enhance food interacting with the fundus to suppress the ghrelin, not vice versa.
No, the question was asked because the way full sense is acting, you create a early satiety. Why not the balloon can do that? That's a this reason why.
That's a different question. The full sense is a cardia mechanical receptors, and that's different than the fundus. The fundus is a accommodated organ. The cardia is not a very accommodating organ. So once you look at the cardia, any stretch on the cardia triggers immediately this response to the brainstem, which is really different than the fundus that's accustomed to doing this and this. So yes, if you could fix balloon to the cardia, that will have a similar effect, but then you're going to be obstructing the outlet of the esophagus and you're going to have symptoms. So hence the balloons have a different mechanism of action than the full sense device.
Okay, before Dr. Vivek asked the question to Dr. Nagireddy is, has anybody studied lateral surface of the duodenum and medial surface of the duodenum with the histology electron microscopy to see the incretin and anti-incretin receptors, so that in an imbalance happening in obesity, you will know that what kind of treatment modality. This is just my question I'm asking you. In fact, I was telling my postgraduate, okay, we'll do the electron microscopy, the lateral border, how it looks like, medial border, how it looks like, how many receptors for anti-incretin, how many for incretin. Maybe a scientific fiction question. I know you are smiling.
I'm also smiling also, TSC, because we know Nagi is biased towards the medial wall. So Nagi, this you cannot answer.
No, he does so he's biased to medial wall.
Medial wall has a focal area called the papilla, and I know Nagi is very biased.
Electron microscopy studies, see the receptors and the.
No, I think I was smiling because the typical TSC question, very innovative. I never thought of it actually. There no, as far as I'm aware, there are no studies which actually looked at different walls. I would think that there may not be a difference, because the population of the cells, when they enter into the duodenum, would repopulate the whole mucosa. Now, in the food also, when it goes into the duodenum, is actually touching all the walls of the duodenum. So I don't see any reason, but I think it's a very interesting concept, as usual, that you put forward.
The question I asked is, the cell secreting anti-incretin has to be different from cell secreting incretin.
Yes, they're enteroendocrine cells.
Microscope wise.
The best way to study them, of course, would be to do immunohistochemistries and all. But what happens is these cells are present in the mucosa, distributed. When we depict them on the cartoon, of course, it's nice to show them two different walls so that they look very nice on that. But I think in real life, it happens in a different way, like everything else.
So it is not predominantly located to lateral and medial wall?
No, I don't think.
But you do the mucosal surface resurfacing of the medial wall only?
No. Mucosal is everything, because it's a balloon which is circumferential. Resurfacing is circumferential.
So the cartoon is just to impress the...
Cartoon is to make it simple. Sometimes they don't, as endoscopists, we don't want to think so much. We want to make it very simple so that you can understand.
Okay, over to Vivek now.
No, that's why I think, and Nagi actually a nice segue, because this is a very high intensity cognitive and cerebral discussion. But I do know that attendees and many folks are looking to start these programs have very practical questions as well. So just to balance the discussion for both Nagi and Abu, Abu Day, Dr. Abu Day, two questions back to back they can answer. Bharam, you can start first. Is very briefly, how do you envision setting up such a program? What are the essential components of setting up a metabolic program in an institution that is interested? And second part is, how do you go about case selection? So if you can shed some light, each of you, back to back, please. Thank you.
You have to unmute Professor Diane.
Thank you. So Nagi, if you don't mind, if I could start, because they're paging me and I have to go do a case in the hospital. I apologize. So the part of establishing your program is just like any new technology that we have, is you have to have the right partners. And the right partners is, we've been emphasizing that this is a chronic disease with multiple specialties intersecting with the patient, and nobody have a claim on these patients, because these are really true a team patient rather than an individual doctor patient. So you just need to develop these ties with your colleagues in order to offer the full spectrum of intervention. So the principal components is psychology, behavior is a key. Behavior before the intervention, I don't think it's very useful. Once the patient loses the weight, that's where they're engaged, and you could have a shot at changing these behaviors, as Dr. Anil said. So you need your colleagues from nutrition, because healthy nutritional habits is also a very critical component. And by the way, the nutrition is not always the healthy Mediterranean diet. The nutrition is whatever works for the patient, with the concept of caloric restriction. So whatever diet it is, healthy or not, the concept is more important in caloric restriction and cognitive restraint rather than the macronutrients themselves. Then, of course, you need your colleagues from endocrinology. We're venturing into areas of metabolic disease, diabetes management, insulin changes, and you need to have an endocrinologist on the team. And obviously, you have to partner with your colleague of bariatric surgery, because it's a two-way street, right? Patients who do not qualify for bariatric surgery, which is the vast majority, could qualify for bariatric endoscopy. But patients who fail bariatric endoscopy, now they're sensitive for a surgical option, and they could graduate to bariatric surgery. And we're seeing a lot of patients going back after bariatric surgery to management of weight regain. I could tell you we do about 5 of these a week. So having these components and establishing trust and working relationship is the key of success. All the details will fill in once you have the team in place to achieve that.
Thanks. Nagi?
Yeah, I think I agree with Barham. In fact, the most important thing we realized when we started, in fact, we started a metabolic unit in our hospital. The most important thing is that this is a multi-system team effect. In fact, the most important thing is to actually include your bariatric surgeon into this, because if you don't include your bariatric surgeon, there's a turf war between the bariatric surgeon and the bariatric endoscopist, then that's finished. So ideal would be to have a surgeon, an endoscopy team, the nutritionist, the endocrinologist, the psychiatric counselor, all sitting in the same area. So we have created an area where all of them sitting together, and every case that walks into this metabolic unit is seen by the manager first, and then the counselor, and then the surgeon and the endoscopist together make a decision what to do in the patient. A very morbidly obese patient, one of course doesn't want to do endoscopy, and maybe surgery is better, and so on. So I think this is a very important concept. They come together, and in fact, Vivek, I think regarding the training part, these procedures are very easy to do. They don't require special endoscopy skills like other difficult endoscopic areas. They are very easy to perform. It's just that you set up a good program, so these patients are going into the right direction, and they followed up in the right way. And it's a sustained program. It has to be long term.
That's true. And I think, going back to when we started this at our center, I think 12 to 18 months were spent upfront, really, at least a year, if I remember correctly. We had a very high volume bariatric surgery, still have programmed. At the time, they were doing 400 plus gastric bypasses, which was a big number 10 years ago. And it took us a while to get them on board because bariatric surgery was so popular and so efficient and so effective at getting the job done. We were walking in with, at the time we had a balloon. That's all we had. So a lot of groundwork, but it has stood us the test of time. In fact, that's where most of our patients come now. So I think that's really important, and case selection is key. I know Baram has to leave as well, I think. So we want to thank him. Baram, are you leaving now? Are you going to stay on for a couple of minutes? Or
I could stay for a couple of minutes if you'd like.
Okay. We want to thank you for your time today and for the excellent presentations. And I'm sure the attendees, benefited significantly from that. Anil, I just wanted to ask you, a big impediment in the US has been cost, because we don't have coverage for most of these procedures yet. And so is that a similar paradigm in India? How do you reconcile the cost factor, coming into these interventions from a patient perspective and from a health systems perspective?
Yeah, I think that is an important issue, but I'll tell you our story as a hepatologist. Most of the patients who come to us, they do come to us with fatty liver. When you see the patient, you are not having a prismatic vision of just looking at SGOTPT. You look at the total scenario of diabetes, hypertension, obesity. And surprisingly, at least in North India, people are not bothered about their weight. They're not bothered about their obesity, hypertension. They said, "Kid, you are a hepatologist, just talk of SGOTPT elevation." They are more interested in taking care of the liver. So whenever we want to talk to them about the total scenario, about the impact of the metabolic factor onto the liver, and liver just being an incidental bystander of the total situation, not many were able to convince to go to the surgeons for better treatment of obesity, which will take care of everything, including diabetes, hypertension, metabolic syndrome, and liver. It's very difficult for us to convince because they have not paid our fees to get an opinion of obesity. I don't know what is the opinion of Dr. Chandrasekhar and Dr. Reddy. So North India is very difficult to convince. They think you are a liver specialist. Why are you peeping into our obesity? I'll have comments of Dr. Chandrasekhar and Dr. Reddy.
You are right. Not only North India, everywhere the human nature is like that. And the more obese people, they think they are prosperity. And they feel very healthy also. Because we see some cachectic cancerous patient, and contrasting, you see obese patient, they are happy.
That's
so
right.
you are liking always chubby child also like. So the whole concept is like a social, cultural, and everything. The one thing is I liked Nage's comment is multidisciplinary team approach. The one of the most important is psychologists and psychiatrists. Suppose Nagi, a psychiatrist, says that is unlikely to hold on with this diet after even the balloon or anything surgery, like see in alcohol patients before doing liver transplantation is unlikely to stop or something like that. You have pointers like that. Obesity, you have pointers. Okay, we will not do with anything for you, and kind of approach is needed. Or what do you think?
Yeah, I think again the important concept, TSC, as you said, we assume that obese people are healthy. That's a general society's thing, that if you're obese, you're healthy. The point first coming to what Vivek said about affordability, I think generally obese people can afford most of this treatment. They became obese because they can afford, otherwise they wouldn't have become obese. So that's the first point. The second point is that regarding, I think like all diseases, there comes to a point that you get to a point where you know that these patients do not respond to this particular. For example, lifestyle changes and all would be somebody who was say 27, 28, 29 BMI. But if somebody was 35 BMI, I'm sure he won't respond to lifestyle. And about 40, I would not even think of endoscopy as sex, only for a short term to put a balloon to decrease so that he can go for definitive surgery. So we have gross guidelines to say which patients are likely to resolve with lifestyle, which patients for endoscopy. So 30 and 35, maybe endoscopy is still option for these patients. And about that surgery, we have gross option. But there are certain patients I've had who are so fond of eating that it's pitiable to ask them to go through all these things. Let him live his life eating well, and maybe he'll live enough to eat well, enjoy his life, and die. So I think sometimes, like alcoholics, when they come to a terminal stage of alcoholism, we don't want to stop him from taking his alcohol. Like he should enjoy alcohol responsibly. So that's a
The
very
one-
small group.
Right, actually. The one indication for balloon I found it just before the marriage.
Yeah.
So happened that a bride and a groom, would-be bride and groom, they got the balloon done. So I was invited for the reception. I saw that I couldn't identify who is the bride and the groom. And next day, the bride's father and mother and groom's father and mother also came for the balloon. So entire family became a balloon family. So I think we have to try to tell them that not all balloons. So just want to reduce 10 kilos, okay, or is a heavy diabetics, or you are planning for liver transplantation, something like that. As Nagi said, 40, you want to bring it to 35 to reduce the complication. Balloon works out very well. I have a very important question to the chat box. The hunger pang is coming up now. Now, when do we? Now we have done with the most of the questions here. So I think essential hunger, you said, no, Anil?
Yeah.
That's coming up now.
So yeah, homeostatic hunger is back.
I must
Yes.
congratulate all the speakers. A wonderful way of conducting this is the need of the hour. Absolutely, I enjoyed it as much as my co-moderator Vivek also will tell you that, and I enjoyed it thoroughly, and it's thought-provoking. And this is the current setting, and this is contemporary topic, and nice titles, and happy ending before Vivek calls something.
No, very nicely put. Not much more to say. I think this was very covered a lot of ground, and almost 3 hours have passed, and it's not easy to hold anybody's attention for that long. I hope the attendees benefited as much as we think they would have. I do feel for some time now, whenever I visited India, talked to my esteemed colleagues there, I think obesity management has really emerged as one of the most sought after clinical topics, and I foresee this being a space, Anil, for your interest as well, that this could be a solid fulcrum for Indo-US collaboration, even going forward, not just from clinical practice paradigms, technical tips and tricks, but also for trainees, as Barham mentioned. The future is indeed bright in this space, and there's a potential for significant collaboration, clinical research, and education across the continent. So on that note, I want to thank Anil, and please take over from here. Thank you for the opportunity. It was a real pleasure for me as well.
Ashish, like to conclude?
Yeah. So we have come to the end of the session. We had 4 interesting talks and a very lively discussion on endoscopic management of obesity. So at the outset, I would like to thank Dr. D.K. Bhargav, who graced this occasion, and he also shared the history of gastroenterology in India and how endoscopy and ERCP all started. Thank you, Dr. Bhargav. And then I would like to thank the moderators, Dr. Chandrasekhar, Dr. Vivek, for making the discussion so lively and joining from US and India. And I would like to thank all the speakers, Dr. Vivek, who had to catch the flight, Dr. Vivek Kumbhari, Dr. Barham, who also had pagers coming for his patients, but he stayed, and Dr. D.N. Reddy and Dr. Anil Arora for their lively lectures and the very good discussion. I would also like to thank Dr. Vikas Singla and Monish Sachdeva, who are my colleagues, for chairing the session. And at the end, I would like to thank the micro labs, who are the academic partners for this session, for all the logistic support. So we will soon announce the next webinar and who will be the next recipient for the Dr. S.K. Sama Award. I will soon circulate this information. So with this, I would like to conclude the session. So Dr. Arora.
Thank you, Ashish. I think hopefully that should be a happy ending of the hunger pangs. And then we go back to have our satiety hormones coming up again. Thank you so much for everybody for joining. And it was a pleasure and honor to have you all, and hope to see you again soon. Good night and goodbye to everybody.
Thank you so much. Thanks, Anil. Great job, team.
Okay.
Thank you, everyone.
Okay.
Thank you, sir. Thank you very much. Yeah.